Hello, Harita. Hi, good morning. Welcome back to another new session. Today, we are going to start with a new topic on central nervous system. If you guys can hear and see me properly, then you can give a thumbs up or you can tell a yes. Okay, cool. You're able to hear and see properly. Fine. So, very good morning. And sorry for the mild delay again because of the same connectivity issue. I want to make sure that the Wi-Fi kicks in. Otherwise, it will be very difficult. That's why. And good morning, everyone. Good morning, Naveen. Good morning, Abhiram. And good morning, Sundar. Good morning, Patil. Good morning to everyone. And I think you'd have all learned something new till yesterday. Today, it's time to move to neurology section. As far as neurology is concerned, it's again another ocean. And the problem with neurology is it's not that quite interesting like cardiology, to be precise. But when you want to know what you really wanted to know for practice, it becomes really interesting as far as neurology is concerned. That's what I'm trying to do. Maybe I'll take 1.5 to 2 days of neurology so that we'll discuss on the most important stuff that is important for exams. And at the same time, that is important for your routine day-to-day understanding of neurology as well. Neurology can be divided into separately into neuroanatomy, neurophysiology, and separately into neuropathology and neuroscience, and you have neuromedicine, then you have neurosurgery. And if at all you want to add, you have neuropsychiatry as well, and other divisions like neuro-ophthalmology and neuro-otology is also there. So when you want to discuss each and everything separately, it's literally impossible, and each and every of these domains I told you itself needs 1-2 days of separate discussion. So that's again not going to be really possible in any sort of classes, or even if you study on your own, it's going to take years. So definitely that's not the way to learn right now. So as far as neurology is concerned, I'm going to break down into small chunks so that we'll be discussing on topics that are important, that has to be relevant for exams. At the same time, we'll be discussing on certain aspects that are the niche, like that's going to be of, like small tricks and tips. So that's what you're going to learn. So neurology is something that has to be oversimplified according to my perspective. It is one area, there is no problem in simplifying that. There are some areas like endocrine, nephro and all where you tend to complicate a little bit, that's fine. But neuro is one area that has to be oversimplified so that you understand things better. And usually, like in the last 2 years or 3 years, if you take what are the questions that are coming from neurology, if there are 2 questions that are coming from neurology, and both the questions will be asked from stroke. And maybe one more question, if it comes, they can ask from some neurologic infections. So I think so we have to concentrate more on the stroke. So that's what the most important thing is. So that is the first topic I'm going to discuss as well, which is a very common thing that you see in your practice. At the same time, one of the very common questions that you're going to ask. Shubham is asking the sequence of topics to be covered. I have no idea. So I thought neurology can be done because many students have been asking for neurology so that they believe that cardio and neuro are their entire medicine and you don't have any medicine after that. So that's what many students are believing. So that's why I wanted to finish neuro first. I'll be taking stroke first. Then probably it depends. Maybe after the first topic is stroke. After stroke, whatever topic we wanted to discuss, I can discuss, not an issue. Endocrine be done in live class. Yes, I'm planning to do endocrine also. If if the 10 days whatever we have planned is difficult, then we'll be extending the session later on also. Not a problem. It will be extending into the October also. Some few days I'll be doing anyways. My idea is to finish this express at least to an extent completely so that students will get benefit for the NEET PG exam at least. So anyways, let us start with the stroke first. So as I discussed, this is the first topic. This itself is having a huge amount of information. At the same time, we need to know the relevant neuroanatomy as well, which will be discussed in the same section. So first of all, as far as stroke is concerned, the classification of stroke is very important. As far as the classification is concerned, you're going to divide the stroke into probably an ischemic stroke, or probably I can tell hemorrhagic stroke, and we can have some special types of strokes as well, which we'll be discussing separately. As far as the ischemic stroke is concerned, It can be again divided into two. One is called thrombotic stroke, or I can write like a large vessel stroke and a small vessel stroke. So one you can divide into a large vessel stroke, and the second one you can tell you have a small vessel stroke. Everyone knows what do you mean by the small vessel stroke. Anyone can answer this. A small vessel stroke is what we refer to as something called a lacunar stroke often. There are few questions that you'll be getting from lacunar stroke as well. So we'll be discussing about that entity in some time. And as far as the large vessel stroke is concerned, it can be further divided into thrombotic stroke and embolic stroke. Thrombotic stroke and embolic stroke. And as far as the hemorrhagic stroke is concerned, you have two types of hemorrhage. One is going to be the intracerebral hemorrhage. That is, I say it's not intracranial. All the hemorrhages are intracranial only. So intracerebral hemorrhage, and you can tell extracerebral hemorrhage as well. Cerebral hemorrhage I can push further into hypertensive ICH and non-hypertensive ICH. That's the easier way to classify, because hypertension forms a major chunk of intracerebral hemorrhage. And you have extracerebral hemorrhage where you have your extradural hematoma or extradural hemorrhage, or subdural hematoma, subdural hemorrhage, and you have a subarachnoid hemorrhage as well. These are the three types of extracerebral hemorrhage. And you have some special types of stroke. And you have multiple different special types are there, but as a beginner level, you need to know three important special types of stroke. One is the cortical venous thrombosis. Why it is special type? Because it's a venous stroke. It's not an arterial stroke. And second, we have a dissecting stroke, which is a completely different pathophysiology. So dissecting stroke can be due to either aortic dissection, or it can be due to carotid or vertebral dissection. Carotid or vertebral artery dissection. There are two types of dissecting stroke are there. And finally, you have stroke syndromes, like very common stroke syndrome that they tend to ask in exams is CADASIL. Apart from that, stroke has multiple etiologies, but my idea is only one thing, to make it as simple as possible so that it will be very powerful to answer questions in exams. At the same time, you don't miss anything in day-to-day life as well. So that is my idea. So I don't want to confuse you with so much of etiologies, so much of other vascular etiologies, demelting etiologies. So let us keep it very simple. And these are the overall common cause of stroke that you encounter in day-to-day practice and in exam. So now being said, the usual classification of stroke and the types of stroke, it's better to tell what is the most common stroke among all. So we, of course, know it is ischemic stroke. That is going to be the most common, without a doubt. Of course, among the ischemic stroke, it's the large vessel stroke. There's a lot of controversy in that, but still we believe that large vessel stroke is going to be the most common. Among the large vessel stroke, which you believe is the common, thrombotic stroke or an embolic stroke? Thrombotic stroke or embolic stroke? Yeah, people believe it's thrombotic stroke, but actually it is embolic stroke. That's quite common compared to all. So, and in fact, the thrombosis in CNS is quite rare. You don't really get thrombosis very commonly. De novo thrombosis is what we are talking about. So in coronary circulation, de novo thrombosis is extremely common, but in the cerebral circulation, de novo thrombosis is not that common. It's usually an embolic stroke. And as far as embolic stroke is concerned, you have two different types of embolic stroke. One is called as an artery-to-artery embolus, and second one is a cardioembolic stroke. So among these two, which is going to be the most common? The common entity, according to the textbooks, is it either artery-to-artery embolus or cardioembolic stroke, which is common? Basically speaking, it is artery-to-artery embolus. That is supposed to be the commonest form of embolic stroke. And automatically next question will come. If it's artery-to-artery embolic stroke, then where it starts from? Usually it starts from the carotid bifurcation or internal carotid artery. So it usually originates from the carotid circulation. That is the usual location. Or rarely it can originate from the aortic body also, from the aorta as well. So one of these atherosclerotic plaques can give rise to a embolic stroke or an embolus. So cardioembolic stroke, we know the most common cause, of course, it's going to be atrial fibrillation. So that is also one reason why we do echocardiogram for each and every patient who's coming with a stroke, and we do an ECG for every patient who's coming with a stroke. Remember, 80% of the embolic strokes tend to be artery-to-artery embolus only. 1/5 of the embolic strokes tend to be cardioembolic strokes, and most of the cases of cardioembolus will be due to atrial fibrillation usually. So that's the importance of AF over there. And whenever you talk about a large vessel stroke, it doesn't matter. So there is only one artery that's going to be most commonly involved, and everyone knows that. What is that artery? That's going to be a middle cerebral artery. That's the most common artery that is involved in, even in any stroke for that matter. Even if you take the small vessel stroke, if somebody asks you what is the most common vessel that is involved in small vessel stroke, it's going to be the MCA only. But MCA being a large vessel, you cannot tell MCA directly. You have to tell that lenticular-striate branches of middle cerebral artery. Lenticular-striate branches of middle cerebral artery, that's going to be the most common vessel that will be involved in the small vessel stroke as well. Even in hemorrhagic stroke, again, if somebody asks you in hypertensive hemorrhage, most common vessel, it's the MCA only. But being MCA being a large vessel, usually that will not be involved very commonly. So a small vessel of MCA will be involved, like lenticular-striate branches of MCA will be involved in the hypertensive bleed as well. So MCA is something very important in neurology. You're going to encounter MCA, middle cerebral artery, in a variety of areas. Even for thrombotic stroke, if somebody asks you, I will tell most common vessel to go for thrombosis MCA, which means if they ask you in the brain, in the cerebral circulation, the most common vessel to harbor atherosclerotic plaque is going to be the middle cerebral artery only. And even for an embolic stroke, if somebody asks you what is the most common territory where the embolus will dislodge to, again, it is in the MCA territory, middle cerebral artery territory. So whenever you take any stroke, it has a huge affinity to affect the middle cerebral artery territory. Even though other strokes, I'm not telling it's rare, it's still common, but MCA territory seems to be very commonly affected compared to other arterial territories as far as CNS is concerned. That's why that MCA word is really, really important. So next, coming to the lacuna stroke. As far as the lacuna stroke is concerned, you know it's a small vessel stroke. Usually, most commonly, your lenticular-striate branches. These are the small vessels, which I'll show you in some time. So what are lenticular-striate branches? These lenticular-striate branches are the ones that will be affected. But among the lenticular-striate branches, what will be most commonly affected is going to be the middle cerebral artery. Because lenticular-striate branches are small vessels in the sense it can come from MCA, it can come from ACA, it can come from even internal carotid artery also. Direct branches of internal carotid artery also can sometimes give rise to lenticular-striate branches. So lenticular-striate is not a name that is going to be exclusive for middle cerebral artery only, even though many students believe that it's exclusive for middle cerebral artery. No, it can originate from multiple different areas, multiple different arteries, including AC and anterior carotid artery, which is a branch of IC. But MCS lenticular-striate branches are the ones that are going to be very commonly involved in a small vessel stroke. Suppose if you want to know how to differentiate a large vessel and a small vessel stroke, it's going to be extremely simple, because large vessels are the ones that are going to typically supply the cortex, we know that, whereas the small vessels are deeper penetrating vessels, and they don't supply the cortex, and they supply the subcortical areas. If somebody asks you what is the one important sign that differentiates, or one important symptom that differentiates a large vessel stroke from a small vessel stroke, so what will you answer? So I can answer very simply, because the large vessel usually supply the cortex, and of course any patient with a large vessel stroke is going to have something called a cortical symptom and sign. So this is going to be the most important differentiating point. So they're going to develop these cortical symptoms and signs. So next question they will ask you, whenever you utter the word cortical symptoms and signs in exam, so they'll be surely asking, what do you mean by cortical symptoms and signs? So I can tell many symptoms are there, but first thing that any student should utter from their mouth is aphasia, because the speech and language are very important cortical features. So aphasia is a very important word, and any stroke, whenever the patient presents to you, the first thing you're going to think about is whether the speech and language is affected or not, because you're going to ask questions from them. So it will be very obvious. This is the first cortical symptom and sign that you generally look for: speech, aphasia, language issues. And apart from that, many things are there. For example, you can tell a calculia. Calculation is a cortical function. You don't do calculation in the spinal cord. Then you can tell agraphia, then apraxia. Then so many things are there. So yes, alexia. So whatever it is, you write with A, like ebulia. So whatever may be the fact, I'm just told some examples. I didn't tell everything. There's a long list of cortical functions. So if that is lost, then you're going to result in something called a cortical symptoms and sign kind of a scenario. And usually that is a very common feature of a large vessel stroke. And you will be purely knowing what you mean by this small vessel stroke, even though the pathophysiologies are different, but still you know that these small vessel strokes are going to affect the subcortical regions, and they're not going to affect the cortex by any ways. So if somebody asks you how to differentiate a lacuna stroke clinically from a large vessel stroke, it's very simple. I am not going to have cortical symptoms and signs. So that's the most important point. So which means this clinically translates into these patients are not going to have aphasia and etc. So I don't want to write again. So the most important thing that the examiner is going to expect is this point. So you don't have any speech and language issues, which will be very obvious when the patient is going to speak to you. Remember, these patients may have dysarthria, in the sense like they may have that slurred kind of a speech. Motor issues can be there, but they are not going to have any cortical symptoms and signs. And that's why I'm going to tell that these patients are not going to have any cortical symptoms and signs. So that is why one of the important subcortical areas, important subcortical area that should be known by every medical student is the internal capsule. Internal capsule is an extremely important subcortical area. So that is the reason whenever examiner asks, so like this is a very common question in your undergraduate time, isn't it? So whenever you go to the exam and tell to the examiner, they will ask like, okay, now Shubham is answering. So dear Shubham, they will ask, tell me where is the stroke localization? Just with closed eyes, any medical student at any point, they will tell, sir, internal capsule, sir. They'll ask, okay, dear Shubham, so why it's an internal capsule? So he'll be answering, sir, internal capsule, sir. So you have to answer like why it is an internal capsule stroke, why you are localizing the stroke in the internal capsule, why you are localizing in the subcortical region. So the next answer that you should be giving is, sir, patient is not having any cortical symptoms and signs that favors that the stroke must be in the subcortical region. With the constellation of motor and sensory findings that I am getting, this patient's stroke must be localized usually in the internal capsule, and that's the usual site of a subcortical stroke. And then if they ask you what is the evidence that the patient is not having cortical symptoms and signs, then you can tell the patient is not having aphasia, speech language disturbance, even though the patient has dysarthria, but still patient doesn't have any other problems like acalculia, agraphia, apraxia, and so on. So that is how you answer in exam, so that they'll become very happy. So your localization is correct. So that's the most important point. No cortical symptoms and signs, and patient is not going to have aphasia, for example, and that's how you localize the stroke in the internal capsule. That's a small vessel stroke. And as far as the causes are concerned, so the most common risk factor, if they ask you as far as your small vessel stroke or lacuna stroke is concerned, it's going to be the hypertension. Miller-Fisher is the one who first described this lacuna strokes almost a century ago, I think. So hypertension is the most common risk factor for developing this lacuna stroke, that is the small vessel stroke, and followed by you have many other risk factors like diabetes mellitus as well. Previously, it is thought that the pathology is due to something called a lipohyalinosis. That's what they thought to be the pathology, that is going to result in the development of the small vessel stroke and lacuna stroke. What they believed is when you have a vessel, because of hypertension, they go for fibrinode necrosis. Because of hypertension, this is a small vessel, because hypertension typically affects the small vessels. Diabetes also typically affects the small vessels. Even though large vessel atherosclerosis can be accelerated in diabetes and hypertension, but we know that diabetes and hypertension are known to damage the microvasculature faster than the macrovasculature. So of course, they are going to cause fibrinoid necrosis. Hypertension because of continuous high pressure in the small vessels can result in fibrinoid necrosis. That fibrinoid necrosis is going to become hyaline in the vessels. You know, that is the basis of development of hyalinosis. So that hyaline arteriosclerosis. So they have hyaline. Along with that, they also found out there were some lipid that is getting accumulated. That's why they call it as lipohyalinosis. So that's how they named it, lipohyalinosis. And this form of lipohyalinosis results in thickening of the vascular wall. And once you see this thickening of the vascular wall, the flow is restricted. And once the flow is reduced to a critical value, you will result in the development of a lacunar stroke. And this explained one important phenomenon, that there are something called a SLI. What is SLI? This is called a silent lacunar infarct. So this phenomenon very well explained this silent lacunar strokes, where the patient will have this evidence of lacunar strokes in MRI and CT, but they really don't have any clinical features. So that was very well explainable by this theory. But problem is only 15% of the total lacunar strokes are silent lacunar strokes. But majority of the lacunar strokes are symptomatic, in the sense patient present acutely, like how a usual stroke presents like. So that is why the second theory, which became famous and that became the most widely accepted hypothesis, is the microatheroma formation. Which means lipohyalinosis does happen, but currently the neurologists believe that lipohyalinosis is one of the risk factors for development of microatheroma, and lipohyalinosis alone cannot lead to this kind of acute presentations of lacunar stroke. Yes, SLA. SLA means silent lacunar infarcts. And microatheroma in the sense like there should be some atheroma formation. That's because of small vessels, it's called as a microatheroma. So this microatheroma is the currently accepted hypothesis. And this is the one that's going to explain all the acute presentations of the lacunar stroke. And of course, currently, if somebody asks you what is the validated theory, that is the microatheroma formation. And that's what is thought to be the main reason for the development of lacunar stroke. Lipohyalinosis is probably only a risk factor that develops due to a pre-existing risk factor like hypertension or diabetes. So anyways, so microatheroma is what you have to answer. Hypertension as a risk factor, no cortical symptoms and signs in subcortical strokes like lacunar strokes and small vessel strokes. And the most common vessels that are affected is the lenticulostriate branches, especially of the middle cerebral artery. That's all. The most common area that will be affected basically is not internal capsule. It's actually putamen. Putamen is the most common area that is usually affected. But nevertheless, you can remember internal capsule is also associated with the putamen and globus pallidus, and you know, next to the basal ganglia only or internal capsule fibers done. So they might also be damaged in that setting. And here are some types of lacunar stroke. We know that we have many different types. Many books will give many different types, but basically neurologists divide into something called a pure motor stroke, where you have only exclusively motor symptoms. Then you have something called a pure sensory stroke, where exclusively have only sensory symptoms. Usually in pure motor stroke, the problem will be in the internal capsule. If it's a pure sensory stroke, your problem will be in the thalamus, basically, because thalamus is an area of sensation. Then you have sensory motor stroke, so where you can have problems in both these areas, internal capsule as well as the thalamus. Then you have something called a dysarthria clumsy hand syndrome. Dysarthria clumsy hand syndrome, where the problems can be in other subcortical areas like cerebellum, pons also. Basis pontis is there. Even there you can have this problem in case of dysarthria clumsy hand syndrome. Then you have something called an ataxic hemiparesis. Usually the lesion will be in the posterior limb of the internal capsule, again in the setting of ataxic hemiparesis. So there are different types of lacunar stroke. We can't really tell which is going to be the most common or which is going to be the least common. But these are the 5 different categories that have been mentioned in many standard textbooks. If you want to explain more and more, the lacunar stroke alone can be explained, like for the next 1 hour. So that's that much information. I don't think it's generally required. If you know this much, that's going to be more than enough. So that's how we diagnose in clinical practice. And what is the basic definition of stroke? Abhinami is asking. I know, Abhinami, which year you are in? Must be final year, I believe. So that is why you asked for the basic definition of stroke. Which year you are in? 3rd year. See, that is why you're asking the basic definition of stroke. So if you wanted to know the basic definition of stroke, it is not only the focal neurological deficit, the deficit can be in the motor, sensory, or even in cognitive domain. So, and it should be gradual or sudden onset. So it is due to a vascular cause. So that is what we call it as a stroke. Oh, more than 24 hours is called a stroke. I mean, I next want to know what year Indra is in. Which year Indra is in? Indra belongs to which year? Final year. Okay. Okay, so let us see, these kind of things are not valid right now, that after 24 hours only you can call it as a stroke. There's no basic definitions of stroke like that. Any acute onset focal neurological deficit or even a cognitive deficit that is of vascular origin is basically a stroke. Then we have the hemorrhagic stroke now. So we have hypertensive intracerebral hemorrhage and non-hypertensive intracerebral hemorrhages. So basically we know as far as hypertensive intracerebral hemorrhages are concerned, the most common cause is going to be the hypertension. In fact, if they ask you the common cause of intracerebral hemorrhage, I will usually go towards hypertension only. Hypertension is the most common cause of intracerebral hemorrhage. Suppose if you want to know non-hypertensive causes, few non-hypertensive causes of stroke, there are so much of non-hypertensive cause of hemorrhage inside the brain, but few of them are going to be trauma. Quite common. Trauma causing ICH. Everyone knows that. Simple fall. Very common. Among the non-hypertensive causes, trauma becomes the most common cause. Then, of course, if you have coagulopathy, very common. I'm listing out only the common causes that we encounter in common clinical practice. Coagulopathy, especially, for example, if you have warfarin-induced bleed. I think, thanks to, Vijay has asked a question on how to manage a warfarin-induced bleed. I think we have discussed that already. Warfarin-induced bleed, how to manage with 4-complex PCC or vitamin K. Only when you have elevated INR, how will you manage? All these things we have discussed in the previous sections itself. So warfarin, that's an example of a coagulopathy. Or it could be anything else like novel oral anticoagulants, patient on heparin, doesn't matter. Or patient is having a congenital coagulation problem, hereditary coagulopathy, not an issue. So any coagulopathy can produce intracerebral hemorrhage. And next, you have something called as cerebral amyloid angiopathy. So that's called CAA, cerebral amyloid angiopathy. This is going to be really, really, really important. So among all these things, if there are two things that are important, one is the cerebral amyloid angiopathy. Next is the hypertensive bleed. So these are two things that they will be asking. Anyway, traumatic bleeds, you're not going to manage any differently. It will be managed just like other traumatic brain injuries, TBIs, we call it precisely. So apart from that, there is no much use in knowing the trauma. It is important to know for exams this hypertensive bleeds and cerebral amyloid angiopathy. Yes, you do have AV malformations. You do have many other causes. I mean, I'm listing out only the most important causes. And like, you don't see AV malformations that commonly. So these are three things that we encounter commonly. That's why I told you this. Then you have hypertensive bleed. So what are the characteristic features of hypertensive ICH? What are the characteristic features of hypertensive ICH? Hypertension causing ICH. So of course we know hypertension means itself the small vessels are going to be affected. So the small vessels are going to rupture. That is the first point that you should know. As far as the hypertensive bleed is concerned, thunderclap headache, I don't think so. I mean, it can cause, but thunderclap headache is a very non-specific entity. It will not happen only in subarachnoid hemorrhage. It can happen in many other conditions apart from subarachnoid hemorrhage. But in exam, when you talk about subarachnoid hemorrhage and Medberian aneurysm rupture, you talk about a thunderclap headache, all right. But hypertensive bleeds usually happen in the area of small vessels, which means again the most common vessel that will be affected is the lenticulostriate branches, especially of the middle cerebral artery. And there is a name for this lenticulostriate branches of the middle cerebral artery. What is that name called as? Lenticulostriate branches of middle cerebral artery. Yes, these lenticulostriate branches of middle cerebral artery is what we refer to as Charcot's artery of ICH, intracerebral hemorrhage, because that very commonly bleeds. Apart from that, there is another vessel called as recurrent artery of Hubner that can also bleed over there. recurrent artery of Hubner. So this is also a small vessel basically. So this is a one, and this is a recurrent artery of Hubner. So this can also bleed in the setting, and recurrent artery of Hubner is actually a branch of anterior cerebral artery, ACA, which can, I told you, it's not only the MCA that supplies these subcortical areas, even ACA do supply subcortical areas. One of the largest small vessel. It might be double contradiction. I'm telling largest small vessel. Why I'm telling that is because this recurrent artery of Hubner has one important information with it, because it is the only small vessel that is visible in the normal angiograms. Usually these lenticulostriate branches are not visible in the angiograms, basically, when you do a invasive angiogram. But you can see this recurrent artery of Hubner. In fact, this is the only small vessel that is actually visible in the angiogram normally, and it's a small vessel. So that's why that has a lot of importance. So that can also bleed a lot of times, and that can produce hemorrhage in that area. And all these vessels, if you see, they are going to supply the subcortical areas only. And that's why it's very common to understand what is the most common site. It's important to understand what is the most common site that is going to be affected in the setting of intracerebral hemorrhage. Of course, we know what is the most common site. It's going to be, everyone knows. What is the most common site for ICH? Hypertensive ICH. I'm not talking about non-hypertensive causes. Hypertensive ICH. Yes, of course. It's going to be the putamen. Putamen is going to be the most common site of hypertensive ICH. Then, of course, after putamen is going to be the globus pallidus. After the globus pallidus, it's going to be the thalamus, and after thalamus, cerebellum can be affected. And after cerebellum, even pons can be affected. Pons is very commonly affected in hypertensive bleeds. So this is the descending order of involvement. If you see, all these areas are basically subcortical areas. Hypertensive bleeds usually does not affect the cortical areas. Most of these areas are basically subcortical zones only. But cortex can be affected sometimes. I'm not telling no. But majority of the times, most of the times, hypertensive bleeds will be in the subcortical locations. So when it is in the subcortical locations and the bleeding is due to small vessels, hypertensive bleeds generally tend to look very small. On appearance, they might look extremely small. Very small amount of bleed will be there. HGIC, which means you're talking about hemorrhagic stroke. Okay, I should assume HGIC STR means hemorrhagic stroke will have small vessel features only. Usually, yes. Most of the time will have small vessel stroke features only. That's what I'm trying to tell. Most of them will be subcortical in location. So they'll not have cortical symptoms and signs, and the bleeding can be very small and deceptively small. That's what I'd like to tell. So it's not extremely small in the sense it doesn't mean that they'll not be severe. They'll be deceptively small. You might be believing that the smaller bleeds means there'll be no problem. But it's not like that. So you can remember in a way that where you hit doesn't matter. How hard you hit doesn't matter really. Where you hit matters. For example, if somebody hits me on my chest, even with a lot of power, I'll not feel that much of pain compared to if they hit somewhere else in my box with even a lesser force. I'm going to suffer with a lot of pain. So it's not about how hard you hit, it's about where you hit. So these subcortical strokes are going to involve areas that can result in severe disability. For example, internal capsule is a very compressed bundle of fibers. It's a small bundle that carries the entire cortical fibers. So entire cortex is actually streamlined and compressed into a single small bundle. If that area is affected, it's like affecting the entire cortex only. Even though they don't have cortical symptoms and signs, but the motor weakness can be extremely severe. So which we'll be discussing subsequently. So it can cause severe disability. At the same time, if the stroke is in pons, it's going to result in devastating consequences. And if the hemorrhage is going to happen in the cerebellum, because cerebellum is infratentorial, the smaller bleeds also can result in cerebral tonsillar herniation. Compressing the medulla can result in respiratory failure and death. So it doesn't mean that these small bleeds means they're going to be less dangerous. They can be still extremely dangerous, and they can result in significant and severe disabilities most of the times. So don't take it for granted. So these bleeds can be extremely dangerous. In fact, any ICH is highly, highly dangerous. Intracerebral hemorrhage. Apart from that, they can produce ICH in cortex also, if your time is not good, basically, but it's very rare. But as far as the ICH is concerned, you have some certain scoring systems as the mortality, which we'll be discussing subsequently. And then we have this kind of non-hypertensive ICH. For example, let us assume a non-hypertensive ICH. In that, the most important is the cerebral amyloid angiopathy, that is called CAA. As far as the cerebral amyloid angiopathy is concerned, there are some classical features of CAA. Like, for example, it will be very commonly seen in elderly, very old age people, like 70 plus, 80 plus sometimes, so very commonly. And it is due to amyloid deposition. Amyloid deposition on the large vessels, that's really, really important. So it's not off, amyloid deposition on large vessels. So which means it's going to be a large vessel stroke, and it's going to be a cortical bleed. In the sense, like these large vessels are going to be damaged in the setting of cerebral amyloid angiopathy. As far as I tell it as amyloid deposition, there are two types of amyloid that can be causing this cerebral amyloid angiopathy. One is called A beta 42 amyloid, and second one is the A beta 40 amyloid. We all know whenever you have this kind of A beta amyloid, it can result in Alzheimer's disease as well. But what kind of amyloid is going to result in Alzheimer's disease is the key. So remember, this A beta 42 is the one that can result in Alzheimer's disease, and A beta 40 nevertheless will not result in Alzheimer's disease. And this is a very important question in exam as well. Only A beta 42 will cause Alzheimer's disease, and A beta 40 will not result in Alzheimer's disease basically. And to be honest, whether it is A beta 42 or whether it is A beta 40, irrespective of whatever may be the type of amyloid, it can result in cerebral amyloid angiopathy. So that's a very famous question in AIMS. Once upon a time in 2016, they asked that question where they told all patients with cerebral amyloid angiopathy, all patients with Alzheimer's disease will have cerebral amyloid angiopathy, but only few patients with cerebral amyloid angiopathy will have Alzheimer's disease. Actually, that's a true statement, because any patient with Alzheimer's disease will have cerebral amyloid angiopathy, no doubt about that. But not all patients with cerebral amyloid angiopathy will be having Alzheimer's disease. That's a true statement again. So that's very, very correct, isn't it? That's a true statement. That's a very important statement. All the patients with Alzheimer's disease will have some form of cerebral amyloid angiopathy, but few patients with cerebral amyloid angiopathy will be having Alzheimer's disease. So it's not both are exclusive, mutually exclusive statements. And what will be the clinical features of this kind of CAA, that is cerebral amyloid angiopathy? So number one, as I told you, the patient will be elderly, and usually before the development of this kind of hemorrhagic stroke, they'll be having some warning symptoms and signs. Most of the time, this kind of warning symptoms and signs will mimic a TIA, will mimic a transient ischemic attack. So that's really important. So number one, so they're going to mimic a transient ischemic attack-like feature, these warning symptoms and signs. And most of the times, because they are extremely elderly, they'll not be either able to tell these symptoms correctly, or they will be missed out. And most of the times, these are due to warning bleeds, micro bleeds. Small bleeding will happen, but very difficult to pick up in the CT or MRI unless and until you do some, complicated sequences in the MRI. It's very difficult to find out this micro bleeds. So usually do a CT, you don't see much, and you tell like that's okay, and you will send them off. And subsequently, maybe after a few days or weeks, they will come with a massive cortical bleed, that is a lobar bleed. So whenever you talk about a lobar bleed in an elderly patient, elderly lobar kind of a bleed, lobar distribution, the entire lobe is affected. So you always diagnose a cerebral amyloid angiopathy. This is very crucial and very typical of a cerebral amyloid angiopathy, even in real practice. That's how they come, a massive bleed, very elderly patient, 80 plus, 85 plus. Lobar distribution of bleed. It must be a CAA, cerebral amyloid angiopathy. Clear? So, and many of the times in exams, they might give some background history will be there. So, for example, background, either some mild memory loss can be there in the patient, or they can give history of Alzheimer's disease also on treatment. Even a patient who's having Alzheimer's disease coming with this kind of a massive bleed, I will take it as a cerebral amyloid angiopathy only, because all patients with Alzheimer's disease essentially will be having cerebral amyloid angiopathy, which I have discussed already, right? So this is CAA, cerebral amyloid angiopathy. As far as the pathophysiology of the hypertensive bleeds are concerned, so if somebody asks you what is the pathophysiology of hypertensive bleeds, I'll be telling that's going to be because of one important type of aneurysm called as Charcot-Bouchard aneurysms. So that's outpouching of the vessel due to high pressure most of the time. So there will be some small aneurysm formation in these small vessels. These aneurysms are basically referred to as something called a Charcot-Bouchard aneurysms, and that is the one that's going to rupture and going to produce hypertensive ICH in the small vessel territory. And of course, both of them will be completely different. So for example, if there is a ICH, most commonly they will not have any cortical symptoms and signs most often, because they involve subcortical areas, whereas your cerebral amyloid angiopathy patients will have cortical symptoms and signs most of the time, because they are involving a lobar area. They are going to involve the cortex predominantly. So that is the reason. And nevertheless, ICH is going to have a high mortality, whatever may be the cause. ICH per se has extremely high mortality. If you ask about the overall mortality of ICH, whatever may be the size of the bleed or wherever may be the bleed, it's approximately 30 to 40%. So almost, half of the patients really die because of ICH, which means it's not a very good thing to get in reality. And many of the patients who recover also will be heavily disabled. And there is no indication for routine surgery also, that makes the scenario even more complicated. And you have something called as ICH score, a mortality score that's called as an ICH score that has been proposed. And even though it's not very useful, may be useful for exams only. So it depends on certain factors like age. Of course, as I told you, the increasing age is always a problem in neurology. So age more than 80 carries 1 point. And the GCS, if they ask you the most important predictor of the prognosis of ICH, it's the presenting GCS, presenting Glasgow Coma Scale score. So that's going to be the most important as far as the prognosis of ICH is concerned. If 13 to 15, then it carries 1 point. Then if it is going to be 5 to 12, then it carries, 13 to 15 means 0 points. 13 to 15 means 0 points. And if it's 5 to 12 means it's going to carry another 1 point. And in the range of 3 to 4, it carries 2 points. So based on the GCS, it's going to be really important. The score is going to be very high if the GCS is very low. Then if the patient is having an intraventricular hemorrhage, the hemorrhage which is present within the ventricle is going to carry another 1 point. And if the patient is having an infratentorial bleed, which means below the tentorium cerebelli, it carries another 1 point. And if the patient is having volume of the bleed that is more than 30 ml, that carries another 1 point. So if they ask you among all these things, which is the most important, it is the Glasgow Coma Scale, GCS. GCS is going to be the most important, even for subarachnoid hemorrhage, even for ICH, the presenting GCS, even for any hemorrhagic stroke, including a traumatic hemorrhage, the presenting GCS has a very important role, and that's going to be extremely important prognostic factor among all. So this is the ICH score. Of course, the more the score, more is going to be the severity. As simple as that. No doubts about that. And is there any indication for surgery? That's the question now, whether you will treat medically. IVH, like what Amia Ranjan is asking, what is IVH? This is intraventricular hemorrhage. Intraventricular hemorrhage is what we refer to as IVH, if the bleeding is within the ventricles. So based on that, so what I was trying to tell is, like, what is there any indication for surgery in ICH? You can divide into two. So as far as the treatment is concerned, you divide into two, whether it's a supratentorial ICH or an infratentorial ICH. So whatever may be the ICH, the conservative management is very important in the sense, like the routine management, whatever you do, like for example, your BP reduction and probably other conservative measures like reducing the intracranial pressure with mannitol. So these things are really, really important. Conservative treatment is going to be there for every single kind of intracerebral hemorrhage. There is no doubt about that. But whether is there any role for surgery, interventional management, that's the key here. For supratentorial hemorrhages, there is a study called STICH trial, STICH, that's called a supratentorial intracerebral hemorrhage trial. That's called a STICH trial. So this STICH trial was done, I think 2 decades ago, where they found that routine hematoma evacuation, which means irrespective of the ICP status, if you routinely evacuate the hematoma, they proved that there is no benefit with that. So what this trial told is there is no need for routine surgery. In the sense, like I can write, there is no need for routine hematoma evacuation in these patients. So there is no improvement in mortality, or there is no improvement in survival as a whole. So that's what the Stitch trial told, and that's what is the important point for exams. If it's a supratentorial hemorrhage, there is no need for routine surgery. If there is a raised ICP, then I'll do cranectomy and other ICP reducing surgeries. That is fine. So if the patient goes for severe raised ICP, then all that is fine. But there is no need for a routine surgery, no need to routinely evacuate a hematoma. Let it be there, and you're going to treat with conservative management only. Let it get absorbed on its own. And outcome-wise, there is no difference. If it's an infratentorial hemorrhage, then you don't have any trial. For example, first, there is no standardized trial that can tell when you should operate in an infratentorial hemorrhage. But it's been clear that there is one indication for surgery. If it's an infratentorial hemorrhage, that's a common consensus, not backed up by any proper trial, but still any cerebellar bleeds more than 3 centimeters has to be operated. And they will do something called a suboccipital craniotomy, and you have to evacuate this bleed. Because cerebellar bleeds more than 3 centimeters, even if the patient is not exhibiting any signs of ICP, they will, of course, go for some signs of raised ICP later on. They will cause tonsillar herniation because the location of the bleed is like that, because it's infratentorial, and that area is very dangerous because it's a very small area. And if there is a space occupying lesion which can easily push the cerebellar tonsils down, once it comes down the foramen magnum, through the foramen magnum, you are having the medulla, and especially the respiratory zones are there in the medulla, which will be definitely compressed by this herniating tonsils, and definitely will result in respiratory depression and death. Ranak is asking, can you repeat the name of surgery done? Suboccipital craniotomy. Yes, suboccipital craniotomy. That's what we do. That's the approach. So any cerebellar bleed more than 3 centimeters is definite indication for doing a surgery. Less than 1 centimeter, definitely no need to do surgery. You can wait. 1 to 3 centimeters, you can do surgery if there is signs of raised ICP. Surgery can be done if there is signs of raised ICP or evidence of herniation. If anything is there in 1 to 3 centimeters, then definitely you can do surgery. But more than 3 centimeters, irrespective of the clinical status currently that is present, you have to take the patient for surgery. So this is the most important exam question. Indication for surgery in infratentorial bleed, that is cerebellar bleeds more than 3 centimeters, is a definite indication for doing a surgery in this setting. Clear. So now I think now the hemorrhagic stroke to an extent is done. So especially we have completed the intracerebral hemorrhage. Now we have this kind of extracerebral hemorrhage, which also becomes fairly important, especially the EDH, extradural hemorrhage, subdural hemorrhage, and you have a subarachnoid hemorrhage. So that's what I'm going to discuss next. So especially the differences between extradural hemorrhage versus a subdural hemorrhage. And everyone knows this, what is extradural hemorrhage and what is a subdural hemorrhage in this kind of a setting. And more importantly, before that, I didn't tell you one important point in the setting of ICH. Whenever there is an ICH, whatever may be the case, if they ask you the investigation of choice, what will you answer? For any hemorrhagic stroke for that matter, what will be the investigation of choice? Yes, Yardell NCCT, that is non-contrast CT. Non-contrast CT is going to be the best investigation and going to be the first investigation, because non-contrast CT is the one that you can easily identify the bleeds. So that's what you're going to tell. Or any hemorrhagic strokes for that matters, investigation of choice or the first investigation that I'm going to do is a non-contrast CT. Non-contrast CT of the brain. All right. But remember, any patient with ICH, especially if they're having intraventricular hemorrhage, if you have a suspicion of aneurysmal bleed, then it's better to do a CT angiography also, especially if the bleed is located in a non-classic location. You know that if it's a hypertensive bleed, it should be located in the subcortical areas, classic location. Suppose if the bleed is located in non-classic locations, like a lobar bleed is there, but you don't expect the bleed to happen in that area. So whenever a bleed is there in a non-classic location that is not typical of a hypertensive bleed, in all those patients, it's always better to do a CT angiography, because sometimes aneurysmal bleeds can mimic a intracerebral hemorrhage. And many times intracerebral hemorrhage can mimic an aneurysmal bleed, and aneurysmal bleeds can mimic a proper intracerebral hemorrhage. So just because the blood is present in the ventricles, it doesn't mean that it is subarachnoid hemorrhage. Just because the blood is not present in the ventricles, it doesn't mean it is not an aneurysmal bleed as well. So in any case, suppose if you see the bleed in a non-classic segment, or if you see the bleed in an area that is not supposed to happen for a type of hypertensive hemorrhage, then it's better to do a CT angiography along with that once you confirm the hemorrhage. So of course, but they won't ask you this in exam, but the most important thing to know is the first investigation or the best investigation as far as hemorrhagic stroke is concerned is going to be the non-contrast CT only, that is NCCT. And what about the EDH versus SDH difference? And as far as the causes are concerned, as far as EDH as well as SDH is concerned, the most common cause is going to be trauma only. These are basically traumatic bleeds. And at the same time, both EDH and SDH are going to be happening in the frontotemporal regions. That's a common site as well. So frontotemporal region, that is where both extradural hemorrhage as well as subdural hemorrhage most commonly is going to happen. At the same time, both are extracerebral hemorrhages. They are not within the cerebrum. So both are extracerebral hemorrhages, not intracerebral. So these are the three common points between them. Extracerebral, most common cause is trauma, and most common located in the frontotemporal locations. And apart from that, we know EDH can happen at any age, no problem. But SDH most commonly happens in older population, elderly people. That is because, we'll discuss about that. That's because of the cortical atrophy that will make the bridging veins taut, and there is a high risk of bleeding of those taut veins. Anyways, as far as the extradural hemorrhage is concerned, it's basically an arterial bleed. That's what they will give, but it can be sometimes venous also according to pathology. But most commonly, as far as the exams is concerned, you're going to answer it is a arterial bleed. And we know which artery is most commonly affected. Most commonly affected artery is the anterior branch of the middle meningeal artery of the MMA, middle meningeal artery. Everyone knows middle meningeal artery, but some students may not be aware that it's the anterior branch of the middle meningeal artery that's going to be the most common vessel that will be involved. And where this vessel is usually ruptured is at the pterion. You know what is the pterion? Pterion is the gunshot point. Whenever you tend to suicide, you keep the gun at this point. So this small depression that will be there, there's a pterion where there will be meeting of multiple sutures at this point. And why that point they shoot is because the bullet will easily penetrate, because the skull plate is very weak at that point. And if you get an injury at this area, this is the place where the middle meningeal artery runs, anterior branch of the middle meningeal artery, and that is where it ruptures, causing a extradural hemorrhage. And as far as the subdural hemorrhage is concerned, it's more often a venous bleed. We know that. And which veins are going to bleed, that is also very easy to tell, because the bridging veins are the ones that are going to bleed. These are the bridging veins that generally bleed, isn't it? And there are two presentations as far as SDH is concerned. But as far as EDH is concerned, there is only one single presentation, that is acute presentation. EDH will never be chronic, because it's an arterial bleed. It will be rapid and it will be like catastrophic most of the times. So they're going to have a very acute presentation. So they'll be coming with headache, focal deficit. So remember, any patient who's coming with headache and focal deficit, the first thing you have to think is hemorrhage, even though there are multiple other causes also apart from hemorrhage. But when these two things are there, headache, FND, that especially acute focal deficit, 100%, you have to first think about hemorrhage only. So once you wrote hemorrhage, then you can think about other causes. That's a very, very common entity. So of course, they are going to have a headache, focal deficit. And apart from that, they will be having something called as a lucid interval. Everyone knows that. But this lucid interval is neither sensitive nor specific for EDH for that matters, even though most of the cases the EDH will have lucid interval. But there can be 10 to 20% of the case of EDH where they may not have lucid interval at all. So similarly, SDH is not known to have lucid interval according to textbooks, but practically speaking, lucid interval can be seen in 10 to 15% case of acute SDH also. So it means lucid interval is not very specific or sensitive for extradural hemorrhage, even though for exams, whenever they talk about lucid interval, you always think about extradural hemorrhage only. Okay. So what is a lucid interval basically? So very common history in this kind of patients will be a person who's been hit with some kind of a stick or a rod on the head, maybe during that kind of fights are there, in the road where police sometimes or some other person hits on the head. So that's a common kind of injury you get. Or very commonly in MLE questions, if you take, there will be a cricket ball or a baseball that comes and hit on the side of the head. That's quite common. So what will happen is once that kind of a ball comes and hits you, suddenly the patient, because of the shock that they get, because of that, the patient may go for a little bit of unconscious state. And after that, they will get up. That time the bleeding will be small. And they'll get up. They'll be okay for some time, which means they'll be doing their activities, but not like how they used to do before. But they can be a little confused during that time. Cognitive dysfunction will still be there because there is a bleeding that is happening inside. So once the bleed keeps on increasing, once again, they'll become more drowsy because of the raised ICP, and they'll go for an unconscious state again. So this, initially they got unconscious. Once again, they become unconscious after some period of time. So this period of consciousness, I'm not telling a complete consciousness, but still this period of some consciousness that was there in between two periods of unconsciousness is what we call it as a lucid interval, which is very, very classic of extradural hemorrhage. And they can have seizures. If the raised ICP is too much, they can develop seizures also. But on the other hand, if you take a subdural hemorrhage, there are two varying presentations of subdural hemorrhage. One is going to be an acute subdural hemorrhage, and second is a chronic subdural hemorrhage. Acute subdural hemorrhage is going to have very similar history to that of EDH, but even though it is not that catastrophic, but still it will be very similar to that of extradural hemorrhage. Like for example, they will be having not only headache and FND, they'll have altered mental state. That's very, very important, like altered sensorium. So EDH very commonly presents with very similar kind of a feature. They can have a headache, they can have an altered mental status, they can have focal neurological deficit, possible, they can have a seizure. All these things are possible in acute presentation of subdural hemorrhage also, like EDH. Lucid interval can have, remember, 10 to 15% of acute SDH also can have lucid interval, and 10 to 15% of EDH may not have lucid interval. But so lucid interval I'm not writing here because otherwise you'll be confused in exams. But still, for practice purpose, that's not a diagnostic criteria. As far as chronic subdural hemorrhage is concerned, so usually it happens very commonly in elderly. So acute SDH, usually it is due to trauma. It can happen in any age group, as we told already. But chronic SDH, on the other hand, it's extremely common entity. This is the most common type, basically, chronic SDH. And usually it happens in elderly people. Elderly people who's already having some form of small memory loss kind of a thing, they might be there. And for example, they might be on anticoagulants. Usually in exam, they'll give history of anticoagulants like warfarin or some novel oral anticoagulants, or probably on heparin. Some sort of anticoagulant history they will give, which increase the risk of their bleeding. Because why elderly people? Elderly people, there are two reasons. One, there will be cortical atrophy. So what is the importance of this cortical atrophy? If they have cortical atrophy, they might have this bridging veins are there that connects from the out of the skull to the inside the brain. So these bridging veins, because of the cortical atrophy, decrease in the volume, they'll become very taut, will become very tight. And even with small shearing kind of an injury, because the brain is full means it will not move that much. If the brain is atrophied and small means it will easily move on much within the cranial cavity. So coupled with that, these veins are very taut. If the brain moves violently, even with a small trauma, these veins may be broken very easily, because I used to tell arteries are like balloons and veins are like basically papers. So veins are easily tearable, but they're very compliant, but they're easily tearable. So they might tear and they might bleed, and this anticoagulation history might worsen the bleeding basically. So that's why this anticoagulant history they have been giving. And most of the times they might have a history of very trivial trauma. In the sense, like they may not have history at all. If the examiner is very liberal, they might give a history of extremely trivial trauma. Like for example, a patient is going and hitting on the window. I mean, which he may not even remember, or just, like when he's going, he might hit on the door, or a simple fall in the bathroom. I mean, where you don't expect them to get a serious bleed. So this kind of very trivial trauma history will be there. So that can produce a chronic SDH. And how the chronic SDH is going to present is relatively different. In fact, the FND can be extremely minimal. So they will falsely deceive you, thinking that this patient is having dementia, which means they might come with memory loss. They might come with cognitive dysfunction. Remember, memory is also part of cognition only, but more often they come with cognitive dysfunction, like inability to do their own work. So, I mean, to start with, right now, to give you a basic of cognitive dysfunction, if they are not able to do their own work, that's basically a part of cognitive dysfunction only. Executive function is lost. So cognitive dysfunction, some form of memory loss. So you might be thinking probably this patient is suffering from a dementia. So you might be misconcluding that this is a basically dementia. So dementia-like presentation, very classic of a chronic SDH in an elderly patient. So of course, these patients, you have to do a CT scan. Only when you do a CT scan, you will be understanding that this patient is probably having a subdural hemorrhage. Otherwise, you will be starting to treat like some dementia or even Alzheimer's disease, which is worst. Because if you evacuate this hematoma, these patients get better. So that's why SDH, especially this chronic SDH, is considered to be one of the important reversible cause of dementia. It can produce a dementia-like picture, but it's completely reversible, at least reversible to a large extent when you evacuate this hematoma out. So that is why before you make a diagnosis of Alzheimer's disease, doing a CT brain is extremely important. If they ask you before finally concluding that the patient is having Alzheimer's disease, or before starting therapy for Alzheimer's disease, the most important investigation that you have to do is some form of imaging, either a CT or an MRI. Even though in CT you don't see anything in Alzheimer's disease, only cortical atrophy and maybe mild ventricular dilatation may be there because of the atrophy. But the idea of doing a CT is not to see all those things. The idea of CT is to rule out, is there any reversible cause of dementia like SDH? That's why we do a CT. So before CT, don't diagnose it as Alzheimer's disease. That's the idea. So that's how a chronic SDH is going to present. And many of the times they might have an extremely minimal focal neurological deficit, which means they might not even have a focal neurological deficit. If you very keenly examine, there might be a small right side weakness or left side weakness will be there, which means they will have a very, very minimal focal neurological deficit. Because why I'm telling all these things multiple times, because you will be falsely thinking that this is a dementia in exam. It's not a dementia. If they give this kind of history, please be very clear that it must be a chronic subdural hemorrhage. The next step is going to be a CT scan, not starting treatment for Alzheimer's disease. You will understand when you solve the questions why I'm telling this many times. So now when you do a CT, okay, fine, let us come and do a non-contrast. Of course, you'll do an NCCT. That's the gold standard for all these types of hemorrhage. When you do an NCCT, what you will basically see in the setting of extradural hemorrhage, you're going to see an idli. That's what you're going to see. So you know how idli is going to look like. Idli is EDH. That's what I tell. Idli shaped means it's a biconvex hemorrhage. So it's idli shaped. Idli is EDH. There's a mnemonic for that as well. As far as SDH is concerned, as far as SDH is concerned, it's going to be a biconcave shape, or probably you can call it as concavo-convex or biconcave shape or concavo-convex shape. So, not biconcave, I can tell more of a crescent-shaped hemorrhage. Crescent-shaped hemorrhage or concavo-convex type of hemorrhage. That's how SDH is going to look like. And EDH, on the other hand, is also referred to as lenticular-shaped hemorrhages because they look like a biconvex lens. The reason why you get these kind of hemorrhages are very simple. For that, you need to just understand one basic logic of what's there in your skull. So if you take the skull plate or if you take the skull bone here, so let me draw the probably the dura mater here. So please understand that the dura mater is basically attached to the sutures. Dura mater will be basically attached to the sutures, and that's a very important point. And after that, you have the arachnoid. Then, of course, you have the pia mater, but we know that pia mater will be very closely adhered to the brain. For example, we can probably draw the brain here. And in the midline, you're going to have the falx cerebri, so that I'm giving a small space. So what is falx cerebri? Basically, it is nothing but the dura mater's projection to the center, like this. So this is basically a falx. And this is the brain. And we know that pia mater is something that is very closely adhered to the brain. So I can draw the pia mater, which is very closely adhered to the brain. So if you take the subarachnoid space, this is going to be the space that is present between the pia matter and the arachnoid matter. So you're going to have the CSF here, and there are two other potential spaces. If you see in this diagram, one is going to be the extradural space. So this is the extradural space, and this is where your extradural hematomas happen. And below the dura mater and between the arachnoid matter, you have another potential space. This is what we refer to as a subdural space. And between the arachnoid and between the pia, you have another potential space, that is subarachnoid space, where you have the CSF, cerebrospinal fluid. And when you dig deeper into the anatomy, there are so many structures that is needed. But for understanding this particular SDH and EDH, this must be more than enough for you to understand. For example, if you take a subdural hemorrhage, extradural hemorrhage, the hemorrhage is going to be in the extradural space. So this is basically an EDH. So one thing what you're noting with that of the EDH is very much compressed between the like two sutures. So because it is compressed between the two sutures and it cannot cross the sutures, the bleeding also is very rapid because it's an arterial bleed. Because of high pressure, they have to like swell like an idli only between both the surface, because it has to be limited between the sutures. So it has to swell on both the sides like this. So that is why it gives that characteristic biconvex shape or lenticular shape. And at the same time, the most important point that you can see is it can basically cross the midline, which means there is no restriction at the midline, but it cannot cross sutures because the extradural space is limited by the sutures. That's why it cannot cross sutures. This is a very important point. Many times asked question exam, and that's why even forensic medicine, this is how they find out whether it's a EDH or a SDH. On the other hand, if you take probably subdural hemorrhage, on the other hand, subdural hemorrhage is basically a venous bleed, and it is not restricted by sutures. You can see it can easily cross the sutures, which means on the ipsilateral side, on one hemisphere, they can easily move from one area to another area, but it cannot cross the midline. Because EDH is a low pressure bleed, SDH is a low pressure bleed most of the times, and at the same time, it's a venous bleed. It's not very rapid, and it can easily move between sutures, between the hemisphere. It can easily move from one area to another area. It will be taking the shape of the skull itself like that. So if you take the shape of the skull, it's going to be like kind of a crescent. So that's why it's basically a crescent shape hemorrhage, that is subdural hemorrhage. And more often it can cross the sutural joints, which means it's not restricted by sutures, but it cannot cross midline, of course, because of the restriction by the falx. Cannot cross midline. So these are very important points as far as exams are concerned. And on the other hand, if you take a subarachnoid hemorrhage, the idea is very different. Subarachnoid hemorrhage will be there in this particular location. We know that. Suppose if you encounter subarachnoid hemorrhage, the main feature of subarachnoid hemorrhage is the fact that it will not have this biconvex, or it will not have this kind of a crescent shape. Instead, that will be coming into the sutures, not into the sulci and gyrae. So whenever you see this kind of like hemorrhage that is extending into the sulci and gyrae, hemorrhage into sulci and gyrae of the brain. So that is basically evidence of a subarachnoid hemorrhage only, into sulci and gyrae. Very, very important point. So that's how you tell whether it's a subdural hemorrhage or a subarachnoid hemorrhage or a extradural hemorrhage. So very important points, all these things. And what about the treatment? So now you know what are the characteristic features of this EDH and SDH, and how will you treat these individuals? What are the treats? Of course, EDH is a very problematic entity, which means it's a very rapid bleed. And I advocate treatment for all patients. All patients of EDH should be going for a hematoma evacuation, which means typically we'll go for burr hole surgery. EDH is very easy to take out in the sense because just put a burr hole and you do not touch the brain at all, isn't it? It's just superficial above the brain. It's an extracerebral hemorrhage. So you not touch the brain. You just put a burr hole on a dependent side and the hematoma will be just coming out automatically and you have to just suck it out. Probably using a suction apparatus. So the hematoma is going to come out. And of course, I'm not going to leave just like that. I'll put a small drain and leave it for 24 hours so that if there is any future blood collection, that also will be drained out. And once the drain is free of blood, then I'll be closing the defect. That's all. So that's a burr hole surgery. That's very classic. But still, there are some textbooks that gives indications for surgery. But I don't think really that is important because EDH is usually catastrophic, and without treatment, they might die because they can cause serious midline shift and they'll usually die. But nevertheless, what are the indications for surgery? Any midline shift more than 5 millimeters. This is a universal indication. Midline shift more than 5 millimeters is a universal indication for decompression of anything. Doesn't matter. Even if simply you have to do a craniectomy also. Doesn't matter. Any midline shift more than 5 millimeters is extremely significant. The patient is having focal neurological deficit. Doesn't matter. The patient is already getting a weakness and hemiparesis. So what is the point in waiting in that setting? And if the volume of the bleed is more than 30 ml, like ICH, there is a huge volume, then of course I'm going to do a surgery. So remember, but even though these indications are mentioned in certain textbooks, but I believe almost all EDH has to be evacuated because you don't want to take a risk on the life of the patient. Then what about subdural hemorrhage? Subdural hemorrhage, you have some specific indications. Because not all subdural hemorrhages are dangerous, because especially certain acute subdural hemorrhages can resolve spontaneously. It will be very small, thin paper-like hemorrhages will be there, which is unjustified to be removed, and it will absorb spontaneously. Can cause a mild irritation to the brain, altered mental status, but it's not a big deal. So you can just wait and watch. So of course, when will you, take a subdural hemorrhage out? So you're going to take it when the patient is having a focal neurological deficit, of course, when the patient is having dementia-like features, poor quality of life. So of course, you have to decompress this subdural hemorrhage. Then if the patient is having fall in the GCS, or I can write GCS, admission GCS is very important in any trauma. In acute subdural hemorrhage, if the GCS falls by at least more than or equal to 2. So remember, if the GCS, admission GCS is around 10, 11, then you can wait because it's just an altered sensorium. If it's a very small bleeding, then you can wait. If the GCS falls further by 2 points or more from the time of admission, then definitely it's an indication for removal. Then anisocoria indicates that the patient is going for mass effect. Definitely you have to remove. Or if the patient is having midline shift more than 5 millimeter, which means substantial amount of mass effect is there. If the midline shift is more than 5 millimeter, then once again you have to remove the subdural hemorrhage also. So here what you can do is the same kind of surgery. Burr hole must be enough most of the times, where you try to put a burr hole and evacuate the hematoma. But the problem is subdural hemorrhage, because once you put a burr hole here, it's a low pressure bleed. Sometimes it can move to another side. So again, you put a burr hole there, it can come to a different area. So it's difficult to take. Sometimes it can keep on moving from one side to another side. So as far as you will not do only a burr hole surgery. Sometimes you might be converting that burr hole to a series of burr holes and do a craniotomy also. Sometimes you might be requiring a craniotomy to remove that particular kind of bleed because it keeps moving from one area to another. Yes, Pranay is asking SDH midline shift. Of course, why it can't produce a midline shift? Is there any reason that it should not produce a midline shift? Midline shift is not related to false cerebri. Midline shift is related to something else. So this hemorrhage also can exhibit a lot of mass effect. If it's big enough and if it's significant enough, they can induce a mass effect and they can produce midline shift. Midline shift means the midline just shifts to the opposite line. It's not the false that shifts. We have certain things to see, like pineal gland, or probably we have that septum that connects the two lateral ventricles. That is called what is that? Septum pellucidum. So if that is also one of the important area where you have to look out for the midline shift. So they can well cause the midline shift without any doubt, even a subdural hemorrhage. So these are some important points that you need to know with regards to subdural hemorrhage versus extradural hemorrhage. I think this must be clear. So once we have finished subarachnoid hemorrhage, I'll be teaching you separately because that's completely different. Subarachnoid hemorrhage, or if you want, I can teach now also. SDH, you said doesn't cross midline due to falls. Okay. See, midline shift is different. Crossing the midline is different. Yeah, Shubham Gupta is telling now. See, midline shift is different. Crossing the midline is different. Both are completely different. Okay, so you should not try to confuse that midline shift versus whether it crosses the midline or not. The bleeding crossing the midline is different. Causing a midline shift is different. I mean, I don't know how to explain that. So if you understand, that is different. Like when you see a CT. Priya is asking if CT is not available. What do you mean by if CT is not available? Let me know. I will wait for 1 minute. So what do you really mean by CT is not available? Oh, before that you have asked a question. If CT is not available, how will you localize EDH based on pupil size? I can't understand. So what do you really mean? How do you localize EDH based on pupil? Why should I localize EDH based on pupil size? I mean, what is your exact question? So what do you mean by all your statements? CT is not available, then how will you localize EDH based on pupil size? What does that mean? I can't understand the meaning of that. Okay, Hutchinson's pupil is what you're talking about. So that is due to uncal herniation. That is very classic. We'll be discussing separately when you're talking about mass effect. Pinpoint pupil will be present on which side? Why you should get pinpoint pupil in this setting? There's no, I mean, reason why you get a pinpoint pupil here. Usually you'll get a pupillary dilatation only. Whichever side. Oh, okay. Okay, now I got it. Sorry, Priya. Yeah, now I got it. Priya is asking about the Kernohan's notch phenomenon and a false localizing sign. We'll be discussing that separately. You would have told about that, no? You're asking about a Kernohan's notch and a false localizing sign. You're talking about uncal herniation. That's a completely different entity. So it means hemorrhage cannot move to the other side of the midline due to falx, but it can shift or move the falx, which is midline shift. Yes, of course. I think I have some pictures to show. I can show you some pictures. Maybe I have some pictures, I guess. So if I show you some pictures, you might be well aware of that. Just hold on. So this is one image I can show first. Then I can show another image. So what is this kind of hemorrhage? This simple one only. What is the kind of hemorrhage that you are seeing here? What is this? Yeah, this is basically a subdural hemorrhage only. So it's an acute or chronic SDH. Acute or chronic SDH? Yeah, whenever it is hypodense, it's chronic. Whenever it is hyperdense, it's acute. But here you can see strands of both acute as well as chronic. So you can see that there's some white strand-like structures are there in this zone. So that suggests you of an acute SDH. And you can see a lot of whitish areas on the posterior aspect also. These are signs of acute, and there are intermixed with many black areas, that is hypodense areas. These are chronic SDH. So this is a very likely acute and chronic SDH. Don't you see midline shift here? I mean, don't you see midline shift here? Do you see midline shift or you don't see midline shift? I mean, this question is for people who ask this kind of a question. There's a huge midline shift. And you see, this is the septum pellucidum. Basically, you can see a thin straight line there. I think you can see there is one line there between the two lateral ventricles. So that is the septum pellucidum over there. And there's a huge midline shift. Of course, yes. Does this hemorrhage cross the midline? No, it doesn't cross the midline, isn't it? But it does produce a midline shift. It doesn't cross the midline, but it does produce a midline shift. So this is a very classic subdural hemorrhage. So that's how you tell, isn't it? Now you will be able to get it. So it doesn't cross the midline, but it can produce midline shift. Both are completely different entities. So fine. So you have understood this. Then next, I can show you this image. So what is this one? So what is this image? What is the answer for this? Yes, this is an SDH or EDH in the first place. See, first of all, this must be a subdural hemorrhage. You cannot cross the sutures in a extradural hemorrhage. So it crosses the sutures, like a lot of sutures, it's crossing, spanning a huge area. Definitely it must be an SDH. And it is an acute SDH or chronic SDH. Yes, of course, it's an acute SDH because the blood is white here. So it must be an acute SDH. And do you have midline shift? Yes or no here? Yes, of course, you do have midline shift. So this is an acute SDH. And what is this? Yes, this is idli, of course. So if you see this kind of idlis, so surely it must be a subarachnoid hemorrhage only. Of course, yes. Sorry, extradural hemorrhage only. Surely this is an extradural hemorrhage. And do you see midline shift here? Yes or no? Yes, you do see midline shift. It's a huge midline shift again. So, and it does not cross sutures. If you see how compressed it is between the two sutures, so and it is not crossing the sutures. And what is this? What is this hemorrhage? It's a very classic image you get in exam. So when you use these kind of star-shaped hemorrhages like this, a spider-like appearance, that is subarachnoid hemorrhage, very classic. So where you can see the blood between the sulci and gyre. You can see the blood that is tracking between the sulci and the gyre everywhere. So this tracking of the blood between the sulci and gyre is very classic of a subarachnoid hemorrhage. So what is this kind of hemorrhage? This one. What is this one? See, you see hemorrhage in only one side. See, remember one important thing is in subarachnoid hemorrhage, you usually don't see, midline shift. Are you seeing any midline shift in subarachnoid hemorrhage? Because hemorrhage is equally distributed throughout the subarachnoid space. So usually don't see any midline shift in subarachnoid hemorrhage. That's a very important point. But here you do see midline shift or you don't see midline shift here. My question is yes or no? Yes, you do see midline shift. How can it be a subarachnoid hemorrhage? It's very difficult to get a subarachnoid hemorrhage like this. So it's not really a subarachnoid hemorrhage. It must be a, what is it then? Yes, it must be an intracerebral hemorrhage. So if it's going to be an intracerebral hemorrhage, you think this is a cortical bleed or a subcortical bleed? Cortical bleed or subcortical bleed? So this is a cortical bleed. So if you get these kind of bleeds in an elderly patient in exam, what will you answer in exam? What is the probable diagnosis? Yes, that is a cerebral amyloid angiopathy, of course, yes. Correct. So you're going to answer a CAA. What about this? So what is this? Is this a subarachnoid hemorrhage? Is this a subarachnoid hemorrhage? Of course, no. So this is definitely a parenchymal hemorrhage only. This is intracerebral hemorrhage for sure, without any doubt. But you are seeing the cortical area or subcortical area? Classic type. So you are basically seeing in the subcortical area. So very likely this will be a hypertensive bleed. This is how hypertensive bleed comes. Very, very, very typical. So if you get these kind of bleeds in exam, this must be a very typical hypertensive bleed. And if you see, there is no much midline shift that is caused by the bleed, but still it can result in serious disability. So it's a subcortical hypertensive bleed due to rupture of the small vessels, small vasculature. Okay. Now I think these hemorrhages will make a lot of sense. So let me finish off the subarachnoid hemorrhage also. So what are the important features of subarachnoid hemorrhage that you get? Or okay, in low tertiary setup, if the patient is taken up for surgery for EDH, based on pupillary dilatation, which side you will do a burr hole? I mean, how much ever low tertiary setup you are in, this is a very bad question, Priya. She is asking in a low tertiary kind of a setup, if patient is taken for surgery in EDH based on pupillary dilatation, which side you will do a burr hole, on the same side of pupillary dilatation or opposite side of pupillary dilatation? First of all, practically speaking, this is a very, very bad question in the sense like who's going to take the patient for an intracranial surgery or a burr hole surgery based on pupillary dilatation? Number one, that's absolutely bad. And which tertiary area is going to not have a CT? Which tertiary area, first of all, is not going to have a CT in the first place? I mean, practical point of view, I'm telling, leave the theoretical part. So let us discuss about that in some time. I'm going to discuss anyways. But practically speaking, this is a very, very, very bad one. And I'm not going to do surgery at all. And if you tell this to a neurosurgeon, and it's going to be catastrophic and they're not going to really like it. Yeah, without CT, neurosurgeon won't work. A neurosurgery department itself won't work without a CT. If you really want that. See, remember, suppose, what you're asking is you want to ask, she's actually persistent. Priya is now came to a zone where she cannot move on without understanding that Kernohan's notch phenomenon. So that is what Priya's mentality is right now. So let us satisfy Priya now. So what is that uncle herniation? What is that Kernohan's notch phenomenon? So that's what we want. So let us see that. So what happens is like you have something called tentorium cerebelli. So let us see, this is going to be a tentorium cerebelli. Okay. Okay. EDH midline shift or not? Haritha is asking. After seeing so many images, you're asking EDH will produce midline shift or not? Definitely it will produce. With any mass lesion can produce midline shift, man. So why it can't produce a midline shift? That's the question. Okay. Let us come back to this. So you have a tentorium cerebelli here. There is one important structure that is above this tentorium cerebelli. This is what we refer to as an uncus. Let us draw an uncus here. So this is the uncus of the temporal lobe. And let us draw another important structure here. This is what we called as one important brainstem structure. What is that structure? Can anyone tell what is that structure? That passes, through the tentorium cerebelli. Yes, of course. That's correct. The most important structure that passes is the midbrain. The midbrain is the one that's going to pass here. And from the midbrain, you're going to get one important structure that passes out. That is the oculomotor nerve. So I can draw in a different color. So I can draw, this is the oculomotor nerve, cranial number 3. So that's going to pass from the midbrain and the lower portion of the midbrain. We know that as well. The first thing is the fact that whenever you have a mass lesion, let us assume you have a mass lesion here. So this is space occupying lesion. It could be a tumor or it could be a hemorrhage, whatever may be the fact. This is going to push the structures to the other side, which means either that will produce a midline shift. At the same time, this is going to push the uncus towards the, into the, tentorium cerebelli into the downward region. So you will end up in a situation like this. So where now you'll have the same tentorium cerebelli here, and you have the uncus that is herniated here, and you can see the midbrain that is actually compressed against the sharp edge of the tentorium cerebelli. So this is where the problem is. Now there are two things that are happening. One is this cranial number 3, that is oculomotor nerve, is actually directly pressed by the uncus. So this is the uncus that is herniating down. So where your CN3 is compressed directly. So which means, with respect to the pathology only, you have to tell whether it's ipsilateral or contralateral. If you take, this is the pathology that is on the, probably on the left side. If you take, this is the pathology on the left side, which means you're going to result in probably left-sided CN3 palsy. Left-sided CN3 palsy. And this is the side, which means it's ipsilateral. So that is the side where you're going to get pupillary dilatation. Of course, this is the side where you're going to get pupillary dilatation. And what really happens is, like you would have studied a lot of times, that whenever you have a lesion in the brain, this is a brain lesion, right? The space occupying lesion in the brain. Whenever you have a brain lesion on one side, you have studied, you will get contralateral hemiparesis or contralateral hemisensory loss. That's correct, actually. That's what should happen. But here something different happens. Why? Because this midbrain doesn't only have this oculomotor nerve, it also has something called this descending fibers of the corticospinal tract that comes down. This descending fibers of the corticospinal tract are what we refer to as something called a crus cerebri. So that is the one that comes from the side of the midbrain and forms this descending fibers of corticospinal tract. So what can happen is these descending fibers of the corticospinal tract can be compressed against this sharp edge of the tentorium cerebelli. So which means the corticospinal tract of the contralateral side is basically damaged because of the pressing of the sharp edge of the tentorium cerebelli. So because of that, this, for example, here I can write the right side corticospinal tract in this situation is actually compressed. You can result in left-sided hemiparesis, which means this is quite bizarre, isn't it? You're having a patient with a left-sided space occupying lesion. You expect that patient to have a right-sided hemiparesis, but they don't have a right-sided hemiparesis. Rather, they have a left-sided hemiparesis. This is what we refer to as a false localizing sign, where they have a ipsilateral cranial 3 palsy that's caused ipsilateral pupillary dilatation with ipsilateral hemiparesis, same side hemiparesis. So this is a false localizing sign. Why it's a false localizing sign? If you take only the hemiparesis into account, you might be thinking that the lesion is probably on the other side, that is on the right side of the cortex, but that is not the case here. Here it's of the left-sided lesion causing a left-side hemiparesis is basically a false localizing sign. Why on the same side? Because this side corticospinal tract is affected. The right side corticospinal tract is the one that is actually compressed against the sharp edge of the tentorium cerebelli, and this corticospinal tract obviously will be supplying the left upper limb and the lower limb only, because corticospinal tract doesn't cross at the level of the midbrain. They are going to cross at the level of the medulla only. You know, there is something called a pyramidal crossing in the medulla. So because they cross at the level of the medulla only, so damaging the right corticospinal tract will result in the development of left-sided hemiparesis in this situation. So this is a situation where it will cause a lot of confusion. That's why it's called a false localizing sign in the first place. So if your question, so Priya has asked, like, which based on pupillary dilatation you want to take the patient for surgery. So let us assume it's this left-sided area you have pupillary dilatation, and that is the side of the lesion, which means ipsilateral to the side of the lesion. So in that situation, hemiparesis will be very confusing. So the idea is very simple. It's better to see the pupillary dilatation and not see the hemiparesis. Hemiparesis is not the thing to see because it's a false localizing sign. Sometimes it can be on the right side if the thing is not getting compressed in a significant amount. But as far as the pure Kernohan's notch phenomenon is concerned, the hemipares will be on the ipsilateral side, which is a very confusing entity. So go for the pupillary dilatation, and ipsilateral to the pupillary dilatation, you are going to have your lesion on that particular side. Which side pupillary dilatation is there? That side there will be uncal herniation. If that side uncal herniation is there, means that side should be the side of the lesion. Do you understand? Name of the phenomenon. So this notch, I mean this pressing of the tentorium cerebelli into the midbrain can be really seen in MRIs and CTs. So this phenomenon is what we refer to as a Kernohan's notch phenomenon. Kernohan, Kernohan's notch phenomenon. And this is also referred to as Kernohan's notch sign. So probably this is important for you. And why you develop only pupillary dilatation? In the sense, why you don't develop this ophthalmoplegia? So that's also a question. So why you develop only pupillary dilatation is because if you take the third cranial nerve, let me now zoom the third cranial nerve and take only the third cranial nerve, a part of the third cranial nerve, and see what's happening here. So third cranial nerve is basically made of two kinds of fibers. So one, you have this central fibers, which I'm drawing here, which are basically going to supply the extraocular muscles. And the peripheral fibers are the ones that are coming from the Edinger-Westphal nucleus. These are the autonomic fibers. Yes. So you have the autonomic fibers here. So this is coming from the Edinger-Westphal nucleus. And the central fibers, these extraocular muscle fibers, are basically coming from the cranial nerve 3 nucleus, CN3, oculomotor nerve nucleus. So third nerve has two types of fibers. So whenever you have this kind of space occupying lesion, an uncal herniation or any mass lesion that is presenting. So this mass lesion that is compressing the third cranial nerve can be usually two things in exam. One, it could be uncal herniation. So uncus in the setting of herniation due to space occupying lesion, or very rarely it could be a posterior communicating artery aneurysm. Posterior communicating artery aneurysm. So these are the two options. These are two possibilities you will usually get in exam. So any one of these two possibilities, because of the expansion of a particular structure, they can come and compress on the third cranial nerve. And the first thing to get compressed is the external autonomic fibers. That is Edinger-Westphal nucleus fibers. So there will be relative sparing of the extraocular muscle. So that is why first thing you will get in a compressive third nerve lesion. We have two things are there. One is called a medical third nerve lesion and a compressive third nerve lesion. In a compressive or a surgical third nerve lesion, the first sign you are going to get is pupillary dilatation. There will be no problem in the extraocular muscles. So pupillary dilatation is the first thing you will get. This kind of pupillary dilatation that happens due to compressive or a surgical third nerve lesion is what we refer to as a Hutchinson's pupil. Hutchinson's pupil, or otherwise also referred to as something called a blown out pupil. Hutchinson's pupil or a blown out pupil. Clear? So similarly, on the other hand, if you have a medical third nerve palsy, for example, the very common condition is vasculitis, or it could be a diabetes mellitus. So where this vasa nervosum, there is something called a vasa nervosum. These are small vasculature that are supplying the nerves. A very common example is diabetes. For example, if you take a diabetes mellitus, they are going to affect this microvasculature. These are vasa nervosum. So whenever you affect the microvasculature, of course, these vessels are going to go from outside to inside, which means the deeper fibers are at risk whenever you affect the smaller vessels. These are penetrating vessels. We know that even in heart, we studied the same. Penetrating vessels, when you damage the deeper things, are at higher risk. So in a diabetes mellitus, you will have extraocular muscle involvement very commonly because of the vasculopathy, but there will be a relative pupillary sparing. But it will be a pupil sparing lesion because pupil is outside and the extraocular muscle fibers are inside. In a vascular lesion like diabetes mellitus, it's not a compressive lesion. It will be causing extraocular muscle involvement, which means there will be a third nerve palsy with a pupillary sparing. So if you get these kind of words in exam, it always almost goes towards a diabetic neuropathy or diabetic craniopathy, or you can call it as a diabetic third nerve palsy. So there is a difference between medical third nerve palsy and the surgical third nerve palsy. Compressive surgical third nerve palsies will have first pupillary involvement, that is dilatation on the same side, ipsilateral side, that's called Hutchinson's pupil. Or second, you have something called a medical third nerve palsy that is usually due to diabetes, also called as diabetic third nerve palsy, where there will be extraocular muscle involved. That is, third nerve palsy will be there, but with pupillary sparing is the key answer that you have to give there. I think you get it right. So what's happening over here? Do you get it? What I'm trying to tell? Two types of third nerve palsy. Yes, I think the most happiest person today will be Priya, I think. Hopefully. Isn't it? So she knows which side to operate based on pupillary dilatation. Okay. So then we have one final type of hemorrhage, which will finish off here itself. That is called subarachnoid hemorrhage, isn't it? We still have not discussed on this subarachnoid hemorrhage yet. So let us finish off that. Other name of Hutchinson pupil is blown out pupil. No, like what is there? Okay. Then we have the subarachnoid hemorrhage, isn't it? We have not discussed about the subarachnoid hemorrhage at all. So whenever you take a subarachnoid hemorrhage, you have basically two types of SH. One is called aneurysmal SH. And second one, we have the non-aneurysmal type of SH, that non-aneurysmal subarachnoid hemorrhage. So, of course, non-aneurysmal type of subarachnoid hemorrhage is going to be the most common. Aneurysmal type of SH are not extremely common. And the usual cause of non-aneurysmal type of SH is trauma. Which means even for subarachnoid hemorrhage, the most common cause is going to be the trauma. Which means if you see bleeding in the subarachnoid space, the reason is trauma only. That's why I told you, whatever may be the cause of extracerebral hemorrhage, usually it will be due to trauma only. Most common cause will be trauma only. So EDH or SDH or even subarachnoid hemorrhage, the usual cause is trauma. And at the same time, why your aneurysmal SH is very important? Because this non-aneurysmal types of subarachnoid hemorrhage will be managed similar to other traumatic brain injury, which we'll be discussing later on, because there is some characteristic protocol for how you manage a traumatic brain injury, and you're going to manage in the same way. There is no much difference in that. But on the other hand, your aneurysmal subarachnoid hemorrhage will be managed in a much different way compared to that of the non-aneurysmal bleeds. It has a definitive treatment. You need to occlude the aneurysm or you need to clip the aneurysm. You have definitive treatment so that you can prevent the further bleed. So that's why aneurysmal SH is really, really important. And these aneurysmal SH are basically due to a type of aneurysm called berry-aneurysm. Berry-aneurysms are basically true aneurysms. And these are basically saccular aneurysms, but with a neck. That's why you call berry-aneurysm. So remember, whenever, if there is a vessel that goes for this kind of uniform dilatation throughout its circumference, this is what we refer to as a fusiform type of an aneurysm. Whenever this vessel goes for this kind of dilatation only at a particular place, so this is what we refer to as a saccular type of an aneurysm. And another subtype of saccular aneurysm is there, where this saccular aneurysms will have a neck-like structure and then they will have an aneurysm. So this kind of neck type saccular aneurysms is what we refer to as a berry-aneurysm, which means these are all true aneurysms only. These are not pseudo. Remember, if you have a pseudo aneurysm, we know how it will be there. It will not have all the layers of the vessel wall. Instead, they will have only certain layers of the vessel wall. The best example is dissection. We discussed already. This is a pseudo aneurysm. This is not a true aneurysm. If it doesn't contain all the layers of the vessel wall, it's pseudo only. So all these are true aneurysms. Fusiform, saccular, berry, all are true aneurysms. But berry aneurysms is a type of saccular aneurysm with a neck, basically. That's all. And remember, berry aneurysms can be congenital or it can be acquired also. For example, even mycotic aneurysms are a type of saccular aneurysms only, which can also produce subarachnoid hemorrhage. But that's called a different name because mycotic aneurysm is an infective aneurysm. Even that can cause subarachnoid hemorrhage. So number one is berry aneurysm. Number two is mycotic aneurysm. It's also a type of saccular aneurysm only, but mycotic aneurysms are basically due to infection. So some, for example, most common infection that results in mycotic aneurysm is Staphylococcus aureus. We know that, and very commonly it will be due to background infective enteritis or any Staphylococcus aureus bacteremia can produce a mycotic aneurysm in the brain. And if they ask you what is the defect and where is the defect, site of mycotic aneurysm very commonly in the middle cerebral artery territory only. That's where the mycotic aneurysm very commonly happens again. And usually it will be the junction of MC and ACA, that is anterior cerebral artery. But in the frontoparietal region is where the usual site of myocardic aneurysm formation. And once again, you can think it's the MCA territory that will be commonly affected in this segment also. And as far as the berry aneurysm is concerned, it will happen at very typical locations. And they will ask you what is the defect that is seen in the berry aneurysm. That is going to be the tunica media. Tunica media is the place where you tend to get defect. As far as berry aneurysms are concerned, it's a defect in the tunica media. And the sites of berry aneurysms are extremely specific. There are few sites which you need to know for sure for berry aneurysms. So for that, it's better to draw the circle of Willis. It's very simple. I don't need to draw everything. So first I can draw two vertebral arteries that are going to become basilar artery. These basilar arteries, are going to give two posterior cerebral arteries. These two posterior cerebral arteries are going to communicate with the internal carotid artery through posterior communicating artery, and they give rise to two middle cerebral arteries. This is an internal carotid artery, and they also give rise to two anterior cerebral artery, and you have a anterior communicating artery here. And of course, you have another artery from vertebral artery that is called a pica. So I can draw, this is vertebral artery, this is a posterior inferior cerebral artery, this is a posterior cerebral artery, this is a middle cerebral artery, and this is an anterior cerebral artery. And the dotted lines, what I have drawn, is either an anterior communicating artery or a posterior communicating artery. If you ask about the sites of the aneurysm, so usual, most common site of the aneurysm will be somewhere here. So this will be the usual site of aneurysm. Berry aneurysm is the most common site basically, and the most important site. That is also referred to as anterior communicating artery aneurysms. Anterior communicating artery aneurysms. Or on the other hand, I can tell that this is at the junction. Usually the berry aneurysm's typical site is junction. Myocardic aneurysms may not happen at the junction. They can happen anywhere in the vessel wall. But berry aneurysms typically happen at the junctions of the vessels. In this area, in this condition, you can see in the most common site, it will be at the junction of the anterior communicating artery with the anterior cerebral artery. Or it can happen at the junction of the posterior communicating artery with the internal carotid artery. So these are also referred to as posterior communicating artery aneurysms. Posterior communicating aneurysms. And then you have MCA bifurcation, and you can get a aneurysm at the MCA bifurcation also. These are MCA bifurcating aneurysms. So overall, most common is very simple. It is the anterior communicating aneurysm only, without a doubt. And whether it's MCA bifurcation, second most common, or posterior communicating is the second most common, that's none of our business, and many books will give different values. But I'll tell an overall rule in some time. Then you can take something called a basilar top aneurysms also, which is much less common compared to the other types. These are called as basilar top aneurysms. This is the top of the basilar aneurysms, which means this is the basilar artery, you know that. And top of the basilar artery, you get an aneurysm, that's a basilar top aneurysm. Or you can get aneurysms in the posterior inferior, cerebral artery also. These are called as pica aneurysms. And you can rarely get aneurysms in the vertebral artery also. These are vertebral artery aneurysms. There's a common rule and consensus that as far as these aneurysms are concerned, as you move down from the anterior circulation towards the posterior circulation, so you know this is an anterior circulation, and you move towards the posterior circulation, there is a common notion and consensus that the incidence of these aneurysms will decrease as you move from anterior to the posterior side. A very common notion. By this analogy, you know that vertebral artery aneurysms are going to be the most rarest form because it's most posterior to the circulation. And at the same time, the risk of rupture will increase. Which means anterior communicating aneurysms have very low risk of rupture, whereas these aneurysms, this posterior aneurysm, basilar top aneurysm, posterior communicating artery aneurysm, pica, vertebral artery aneurysms are at higher risk of rupture compared to that of the anterior communicating aneurysms and MCA bifurcation aneurysms. So as more posteriorly you go, the incidence of aneurysm will decrease for sure, but your risk of rupture will keep on increasing. And there are some few causes of berry aneurysm, which means few risk factors, or you can tell it as causes for berry aneurysms. Number one is, of course, idiopathic, and it's extremely common type. And the second common thing that will be expecting in exam is ADPKD. in ADPKD, autosomal dominant polycystic kidney disease, you can get berry aneurysms. We know that. I mean, in ADPKD, you don't get really the brain cysts. Cysts is not a finding of ADPKD in the brain, but you really tend to get this kind of aneurysm formation in the brain. So it's very common. And in fact, ADPKD patients are having hypertension also, that increase the risk of subarachnoid hemorrhage in these patients, because development of hypertension results in substantial expansion of the aneurysm, and that results in a substantial bleeding risk also. So ADPKD is a very high risk disease. If they have an aneurysm, coarctation of aorta can produce, that is again because of severe hypertension in the upper segment compared to the lower segment, because of the obstruction at the aortic level, and you have AV malformations that can result in the development of aneurysm, and you have vascular forms of Ehlers-Danlos syndrome. Not all the types of Ehlers-Danlos, only vascular forms of Ehlers-Danlos syndrome can develop aneurysm. Then fibromuscular dysplasia of extracranial vessels can result in development of aneurysm. Then we have something called a moyamoya disease, very rare disease, described first by Japanese. And of course, every undergrad knows that whenever you talk about a moyamoya disease, you talk about that puff of smoke appearance in angiogram. Clear, isn't it? So everyone knows it. So I don't want to tell that. Angiogram will show that puff of smoke appearance. Vascular type of Ehlers-Danlos. Ehlers-Danlos, you have multiple differential types. I mean, there is no point in discussing about all those right now, otherwise you'll completely deviate from that. So we have vascular type of Ehlers-Danlos syndrome. There are certain varieties which are called as vascular, which affects the vessels predominantly. So they may have, FMD means fibromuscular dysplasia of the extracranial vessels, not intracranial vessels. They can result in development of aneurysm as well. That's due to stenosis once again. So these are some of the risk factors probably. You can think about, or causes probably to think about of berry aneurysms. Important causes. The most important for exams will be probably ADPKD and your coarctation of aorta. So these are the two things that are probably very important for exams, because the examiner wants that two causes. Other things you may remember or may not remember, that's up to you. So then based on the size of aneurysms, you can give some rough idea whether it will rupture or not. For example, if you take the overall average size of aneurysm, is approximately around 7.5 millimeter, that is 0.75 centimeter. That's the average size of any aneurysm. Then we have aneurysms that has risk of rupture, increased risk of rupture. We're talking about the aneurysm diameter. Risk of rupture, when it exceeds 1 centimeter basically, there will be risk of rupture. And remember, aneurysmal size more than 1 centimeter is a contraindication for any form of thrombolysis, including your stroke thrombolysis or including your MI thrombolysis. If a patient is already having aneurysm, and if it's supposed to be more than 1 centimeter, that becomes an absolute contraindication, because beyond 1 centimeter, there is a high risk of rupture. And there are certain entities called as giant aneurysms. So when you call it as giant aneurysms, whenever the aneurysm size exceeds 2.5 centimeter, so we call it as giant aneurysms. So based on the size, you can give some criterion classification, but that's not really important. And based on aneurysms, this kind of aneurysms, these aneurysms can rupture or may not rupture. So aneurysms can be stable, or aneurysms can start getting expanded, or aneurysms basically can rupture also over a period of time. So stable aneurysms which doesn't show any expansion usually will be completely asymptomatic. You cannot detect generally a stable aneurysm. Either incidentally you can find out this in a incidental MRI done for some other reason, but apart from that, it's very difficult to detect a stable aneurysm. On the other hand, if you have an expanding aneurysm, again, most commonly they'll be asymptomatic, or if they produce some symptoms, they'll have very vague symptoms. Very commonly they'll have headache, and they don't really produce any focal neurological deficit. So most commonly they'll have only headache. But one aneurysm can produce a typical symptom, that is the posterior communicating artery aneurysm. It's a very common type of aneurysm also. If you have a posterior communicating artery aneurysm, they can produce that kind of typical ipsilateral third nerve palsy. We have discussed ipsilateral third nerve palsy with prominent pupillary involvement. That pupillary involvement is going to be the most important, which means you will get an ipsilateral Hutchinson's pupil, which means I can call it as anisocoria also. There will be a significant difference in the size of the pupils. So whenever you have an ipsilateral anisocoria due to third nerve palsy and pupillary involvement, and the patient is having a headache, this is a surgical emergency, always. So whenever in exams, even you go to neurosurgery level exam, whenever they give a ipsilateral pupillary dilatation with headache, like there are only two possible diagnoses. One, it's a false localizing sign because of uncal herniation on ipsilateral space occupying lesion, or probably it could be a third nerve palsy due to expanding posterior communicating artery aneurysm. In both these settings, if they ask you next step do a CT, rule out a midline shift and a space occupying lesion. In CT, if you don't find anything, next step is to do a CT angiography in the same setting because it must be a posterior communicating artery aneurysm. There are only two possibilities. So that's why differential diagnosis is very important. These are the two deadly diagnoses because both can be treated. Once the aneurysm ruptures, it's going to be catastrophic. Or even if there is a space occupying lesion like tumor producing uncal herniation, even that is going to be catastrophic over a period of time if you don't treat. In both these situations, the treatment should be urgent, and the neurosurgery consult is very important. That's why this kind of headache with ipsilateral third nerve palsy is a surgical emergency. Pupillary sparing is always a medical problem only. It's unlikely to be a surgical problem. We discussed already. Once it ruptures, it's going to be problematic. So ruptured aneurysm will produce very typical kind of presentation that you will see very typical in exam most of the times. Usually the examiner will not confuse you in a ruptured aneurysm. At the time of rupture, the patient will get an intense and severe headache, and that's often described by many textbooks in a very classical way. We call it as either a thunderclap headache, you call either as a lightning strike headache, so whatever may be the case, or you can call it as a worst headache of your life. I don't know, these are only eponyms that are given for this particular type of headache description, but I don't think the patient is going to tell all these things. What do you mean by thunderclap headache? Any definition, any idea about what is thunderclap headache? Can you tell? What is the definition of a thunderclap headache? It is not coming and going suddenly. So remember, usually headache will take some time to reach the maximum intensity. But thunderclap headache is something that reaches the maximum intensity in no time. So which means it goes to a point of maximum pain, most intensity within a very short span of time. So it has literally no time in becoming the peak severity. So it achieves peak severity in a very few seconds. So that's what we refer to as a thunderclap headache. Remember, the TD for thunderclap headache in exam is subarachnoid hemorrhage and aneurysmal rupture, but it has multiple DDs. Very commonly, we see in our practice something called reversible cerebral vasoconstriction syndrome called RCVS. We have seen so many cases coming with thunderclap headache in that presentation. Even stroke can cause thunderclap headache. So it's not a very peculiar or specific sign for SH, but in exam, always thunderclap headache is going to go towards a subarachnoid hemorrhage only or a ruptured berry-aneurysm. So this rupture is going to result in bleeding for sure. So this bleeding is going to cause a lot of other issues as well. For example, this can result in nuchal rigidity, that is neck stiffness. Very common and classical in a subarachnoid hemorrhage, we know that. And it can result in focal neurological deficit. It can range from simple FNDs like 6th nerve palsy to, it can go up to the level of your decerebrate and decorticate rigidity also. So focal neurological deficit, but if they ask you most common focal neurological deficit, that is cranial nerve 6 palsy. And once again, if somebody asks you why you develop this cranial nerve 6 palsy extremely commonly, then you will be answering that 6th cranial nerve is the one that has the longest subarachnoid course. So in subarachnoid hemorrhage, of course, this is the nerve that will be most commonly affected. And remember, 6th nerve palsy, when you encounter in clinical practice, is always a false localizing sign. There's another false localizing sign like Kernohan's notch. This is also false localizing sign, which means the site of 6th nerve palsy cannot really tell which is the site of the lesion. For example, in subarachnoid hemorrhage, it could be a diffuse lesion where you can develop a 6th nerve palsy, or probably, like 6th nerve palsy is not due to a mass lesion at all. It can be due to anything. So that is why we call it as a false localizing sign. Most of the time, sixth nerve palsy can happen not due to damage in the sixth nerve, that is just due to raised ICP itself. Any condition that produces raised ICP can result in sixth nerve palsy. That's why another false localizing sign, like Kernohan's notch phenomenon, is the sixth nerve palsy. That's another false localizing sign in neurology. So focal deficit. But remember, this sixth nerve palsy, you should answer whenever they ask you the most common cranial nerve or most common FND that is associated with subarachnoid hemorrhage. But if they specially ask you posterior communicating artery aneurysm, whether it bleeds or whether it doesn't bleed, whether it expands or whether it's stable, if they ask you a cranial nerve associated with posterior communicating artery, that is always a third cranial nerve. There is a big love affair between them. We know that, between posterior communicating artery and third nerve. So whenever they tell specifically posterior communicating artery, whatever may be the case, you should answer third cranial nerve only. That's the most common cranial nerve affected in ruptured or unruptured third cranial nerve, posterior communicating artery aneurysm. But in all the other cases, if they ask you any ruptured aneurysm, most common cranial nerve that is affected is sixth cranial nerve palsy only. That's the most common cranial nerve because that's having the longest subarachnoid course. You know that. That's the function of that's one of the important peculiarities of sixth cranial nerve. And of course, they can develop seizures, they can develop brain death over a period of time. One of the important causes of brain death in the world is subarachnoid hemorrhage. Especially traumatic SH is extremely common. They can produce brain death, and one of the important reasons for organ donation as well as brain death. Fine. So the problem is, initially the FND may be less severe, but if you don't treat it, that's why the problem is, because later on they can go for something called a rebleeding. So rebleeding with aneurysm is extremely common. That is why this is something that has to be treated as soon as possible and very, very urgently. Now let us see the investigations. Whenever the patient comes to you with this kind of picture, investigation, the first thing. So whenever the patient tells this kind of acute severe headache, irrespective of the focal neurological deficit, doesn't matter. If the patient tells acute severe headache, of course, I'm not going to take a chance. I'll do a non-contrast CT first to rule out a hemorrhage in this scenario. So once I do a non-contrast CT, it can be either positive for subarachnoid hemorrhage. And this is seen only in 90% of the cases. Approximately 90% of the cases will show the bleed straight away. So now I made a diagnosis that this patient is having a subarachnoid hemorrhage. But a few patients may not show any signs despite having a subarachnoid hemorrhage. So they can be negative for subarachnoid hemorrhage, which means they don't show any bleeding at all, which means the bleeding will be very small. I mean, the aneurysm has ruptured. That's why they got that severe headache. But the bleeding is not that severe due to a variety of reasons. So there'll be slow bleeding. And because there is a slow bleeding, because the CSF is flowing within the brain, that small bleed is easily washed off by the CSF continuously. So it's still leaking. There is a danger, but it's getting washed off by the CSF. So you're not able to see active bleeding or any localized bleeding site in the CT brain. So it can be negative. So that's a small danger is there, which means approximately 10% of the cases, even with the subarachnoid hemorrhage, may show a normal CT brain. So that's why in this setting, if they ask you what is the next investigation that will do, of course, I'm going to do a lumbar puncture and do a CSF analysis. There are few pointers in CSF analysis, because why I do CSF analysis? Because I'm going to look for something called as xanthochromia. Because if the CSF is washing off that blood, of course, CSF should be loaded with that blood. That blood will be, that RBCs that are present in that CSF that is washing off that blood will contain RBCs that will be metabolized by the macrophages. Once the macrophages eat those RBCs, they are going to release bilirubin into the CSF, and that will produce a characteristic yellow color in the CSF. That's what we refer to as xanthochromia. Minimum it takes around 4 to 6 hours for the xanthochromia to develop. It will not get immediately. Usually it will take around 4 to 6 hours. That is the reason first you do an NCCT, and by the time the NCCT reports have arrived, by the time you take the CSF and send it, will have been around 4-6 hours usually. So that's not a big deal. So it will take, but even if you have done CT very early, then you can wait for around 6 hours. Then after 6 hours, you can do a NCCT. If the bleeding is small, of course, the patient also will not have much focal neurological deficit. If the bleeding is severe, then CT must show severe hemorrhage, and the patient will also have some focal neurological deficit. So it's all proportional. The bleeding is very small. You can wait for some time, wait for 4-6 hours. Patient will not have any focal neurological deficit. Do a CSF analysis and then send the sample. And if the xanthochromia is seen, then again you can make a diagnosis. If the xanthochromia is not there, then you can rule out a subarachnoid hemorrhage. It's unlikely to be a SH in this perspective. It's not possible. And one more evidence, in microscopy itself, you can see more than the xanthochromia. In CSF microscopy, just put a cover slip and see. If you see just one macrophage in the CSF, one macrophage in the CSF can be taken as a very good evidence of a subarachnoid hemorrhage, because even if you see a single macrophage in the CSF, what is the business for macrophages to come into the CSF? Because to swallow the blood. That's why they have come. Remember, a normal CSF contains less than 5 cells and all cells should be lymphocytes. There is no business for macrophages should be there in the CSF. Even if you see 1 to 2 macrophages in your cover slip, then definitely that is a very important sign of subarachnoid hemorrhage. Even though you cannot confirm unless until you have a xanthochromia, but you can warn the clinician from the lab itself, telling that this is likely to be a subarachnoid hemorrhage, because in fact there will be plenty of macrophages. But just for exaggeration, I told 1 macrophage. If you see these macrophages, of course it must be a subarachnoid hemorrhage for sure. And they will ask you whenever you see a bloody tab, which means the CSF is bloody. That's called a bloody tab. Whenever you have a bloody tab, they will ask you what is the way to confirm that it is not a bloody tab. I mean, typically in exam, they will expect something called a 3-tube test to differentiate subarachnoid hemorrhage versus a bloody tab. So for example, if you have a bloody tab, what you have to do is you have to collect CSF in 3 separate tubes while it is flowing from the patient's back. So when you collect in 3 separate tubes, in the first, you will have more RBCs. And if it's going to a bloody tab, sequentially the RBCs will decrease, and the third sample you will not get any RBCs. So if there is a sequential or a progressive decline in number of RBCs, or you can also tell progressive clearing of the blood, then it's likely to be a bloody tab. That is because of a traumatic lumbar puncture. That is the usual reason. If there is no progressive clearing, if you see blood in all the 3 samples equally, then it is very likely to be a subarachnoid hemorrhage. But this is not important. The most important thing is the finding of xanthochromia. That's the most important. By some way, whatever may be the ways, you have diagnosed that it's a subarachnoid hemorrhage. So now you have made a diagnosis of subarachnoid hemorrhage through either CSF analysis or through a CT brain. So once you know it's a subarachnoid hemorrhage, and if you suspect an aneurysmal bleed, of course the next step is to do a CT angiography. CT angiography is the next most important step. But even though gold standard is the invasive angiography, we know that. So nowadays we don't do these kind of gold standards. If they ask you gold standard, of course it is a digital subtraction angiography, that's called DSA, but it needs invasive approach. Currently we don't do any DSA. We stick on to CT angiography only. So why CT angiography are doing? Because we need to localize the aneurysm, where the aneurysm is. So this angiography of some sort is going to definitely localize. So once you have localized the aneurysm, you have to immediately start the treatment. Immediately start the therapy. So even before that, if you think it's a CSF, the most important treatment is the BP control, because subarachnoid hemorrhage can happen with hypertension, especially in the setting of a ADPKD kind of a scenario. So it can be a hypertensive emergency also. So if it's an hypertensive emergency, you are going to follow the routine protocol only. Routine protocol to reduce the blood pressure, which I have discussed yesterday itself. Suppose if you really want to know the target SBP, it's approximately around 160 millimeters of mercury, or anything less than 160 millimeters of mercury is fine. So this is the old target, of course. If somebody asks you in exam, you can go for this target. But I believe that according to current ACHA, the routine management, 25% in the first 1 hour, then in the next 2 to 6 hours, you have to maintain BP by around 160, 100. That's the BP we maintain. And in the next 48 to 72 hours, you have to normalize the BP to the baseline value. So that's the usual hypertensive emergency protocol, which I have discussed yesterday. Same thing you can follow here. But there is something called a definitive treatment. BP treatment alone will not help. You need a definitive treatment, because to avoid 2 complications, 2 important complications are there. So one important complication is the rebleeding, and second one is vasospasm. Both are very important and potential complications of So both are very important and potential complications of subarachnoid hemorrhage, and it can cause death also. In fact, rebleeding has extremely high mortality. Suppose if they ask you when rebleeding will start, what is the timing for rebleeding? rebleeding is maximum at day 1, the first day. That is where the maximum incidence of rebleeding is. By around 4% risk is there in the first day after getting a aneurysmal rupture. And it can extend up to day 30. Till day 30, still you have a risk of rebleeding, which means if you don't get it day 1, it doesn't mean that you will not get. So till day 30, you still have the risk. So which means you have to address this very fast. Otherwise, the patient can rebleed at any time, and rebleeding has an extremely high mortality. The initial bleed may not kill you, but rebleeding will surely kill you. It has almost more than 60 to 80% mortality. So definitely you have to address that. And second thing is vasospasm. You have to address vasospasm in a different way. Usual day of vasospasm is around day 4 to day 14. That is the time where the vasospasm will be at peak. Why? Because most of the time in subarachnoid hemorrhage, the blood will be in the subarachnoid space where the entire circulophilis is floating actually. This blood that is present in the subarachnoid space can come and irritate these blood vessels, go for global vasospasm, so global cerebral ischemia. You can even result in brain death because of that. So both of these things has to be addressed. So there are 2 ways. One is to address the rebleeding. So first, you have to address the re-rupture or rebleeding. So how to address the rebleeding? You have to either clip the aneurysm, or either you have to do something called endovascular coiling. There are 2 procedures. Each and everything has separate indications. And again, I'm trying to simplify it as much as possible because we need not complicate it. Each and everything has advantages as well as disadvantages. As far as rebleeding is concerned, as I told you, one procedure is there that is called, aneurysmal clipping, number 1. But the one problem with this aneurysmal clipping is this is a surgical procedure. This is a craniotomy procedure. You need craniotomy for that. You need to cut open the skull and you have to go to the site of aneurysm and you have to clip that aneurysm. And second is called EVC. That is called endovascular coiling. So you don't need craniotomy here because it's an endovascular approach. You can go into the arteries of the brain and you can coil that aneurysm and you can close that aneurysmal site. So that's what we refer to as endovascular coiling. So of course, the preference currently is towards the endovascular coiling. And again, it depends on the size of the aneurysms and all. Giant aneurysms, very lax aneurysms, small neck aneurysms and all cannot be coiled easily. It's a technical challenge and you need a lot of expertise. So in those instances, it's better to go for clipping. But overall, if you want to know the choice, whether clipping versus coiling, most of the cases are now currently taken for coiling because it's easy, less invasive. The morbidity, post-operative morbidity is also very less compared to that of clipping. So, but still there are certain aneurysms which cannot be clipped properly. So in that condition, you have to go for coiling only. There are some characteristic features of the aneurysm which has to be described in the CT by the radiologist. That will help the neurosurgeon to decide on whether to go for clipping or a endovascular coiling. But overall, as a undergrad or postgrad, if you want to answer in exams, coiling is a better option because it has lesser post-op morbidity. And remember, if you want to do these procedures, it's better to do within 72 hours. You should do within 72 hours. This is a rule. I mean, it's better to do ASAP. Remember, these procedures has to be done ASAP, which means as soon as possible, or at least within 72 hours. Within 72 hours, it's better to be done. So quick diagnosis is very important because once you cross 72 hours, you'll go for severe vasospasm, and these procedures become extremely difficult, and you cannot localize. Even in EVC, you cannot push the catheter easily and the aneurysm will shrink and neck will become very small and the vessels itself will not give way easily. And even clipping becomes difficult because of a lot of post-operative surgical complications. So either you do within 72 hours. If you have missed the bus, then there is a huge risk for the patient, which means you have to take after 14 days only. After this 14 days only you can take, even though that is changing right now in the neurosurgery field with the advent of drugs like nimodipine. But anyways, the traditional thinking is if you miss the bus in the first 3 days, it's better to do after 14 days only, because during that time, the vasospasm will be very severe and doing a surgery is going to be more harmful than being beneficial in that scenario. So anyway, things are changing now, but nevertheless, better do surgery within 72 hours. And of course, this is going to be a catastrophic presentation. So where you will not miss the bus. And of course, you will be finding out this much early compared to the older thinking. So then, the second thing that you have to address is the vasospasm, and which is anyway going to happen whether you do surgery or not, because there is anyway blood in the CSF that you are not draining. Address the vasospasm. So addressing vasospasm is basically done through a calcium channel blocker called as nimodipine. This drug is not used for antihypertensive purpose, even though it's a dihydropyridine calcium channel blocker. This is basically an exclusive drug that is used only for subarachnoid hemorrhage. And remember, outside subarachnoid hemorrhage, nimodipine is not indicated. In any, it's a traumatic or any subarachnoid hemorrhage, you can use nimodipine, not a problem. Usual dose is around 30 to 60 milligram orally. 4th hourly we use if the patient is able to take orally, or IV doses also are also preferred if the patient cannot take orally, if the patient is in coma. But nimodipine is a very important drug for your exams, which can reduce the vasospasm to a great extent and can prevent the global ischemia and brain death. So it's a very important drug to be known. And at the same time, most of the times, the surgeons will also do something called a VP shunt, because there is a long-term risk of developing obstructive hydrocephalus, because this blood can form clots, and after some 4 or 5 days, you might develop obstructive hydrocephalus where there is no other option. You have to do a VP shunt. So many of the times, that is one advantage of a clipping. If you're going to open up the brain in the same sitting, you can do a ventriculoperitoneal shunt also. So because it's needed, especially in massive bleeds and all, there is a long-term and a higher risk, especially the patient is having intraventricular hemorrhage, significant blood within the ventricles, then of course there is a high risk of developing obstructive hydrocephalus because of this clots, and you have to take the patient for VP shunt also to shunt the CSF to the other side. And here some scoring systems are there which are also important as far as subarachnoid hemorrhage is concerned. One is called a Hunt and Des scoring system, and second one is called a WFNS scoring. Hunt and Des is a very common thing that is asked in exam, even though the names are very important rather than the actual terminologies. As far as Hunt and Des scoring system is concerned, you have 5 different grades. One is called a grade 0, grade 1, grade 2, grade 3, grade 4, and grade 5. As far as grade 0 is concerned, we call it as unruptured aneurysm as grade 0, which means it has not yet ruptured. Grade 1 is the time where you're going to get only headache with a little bit of nuchal rigidity can be there. That is grade 1. In grade 2, the patient will have severe headache and nuchal rigidity. At the same time, additionally, patient will have focal deficit, especially in the form of a cranial nerve palsy. And most common cranial nerve, we know it is a cranial number 6, except the posterior communicating artery aneurysm, where it's going to predominantly involve the cranial number 3. But there will be some cranial nerve palsy, but beyond cranial nerve palsy, there will be no other focal deficit. That is grade 2. As far as grade 3 is concerned, you still will have an FND, but it will become more severe here. So where they, apart from getting cranial nerve palsies, they might get hemiparesis. But usually this kind of hemiparesis will be mild, power of around 4 minus or 4 plus, nothing more than that. In grade 4, you get more severe FND, where still you will get hemiparesis, and it will be extremely severe, which means power will be 0 to 1 out of 5. And grade 5, you will get posturing, this kind of decerebrate or decorticate posturing, plus or minus coma. The patient will be in coma completely. So this is grade 5 Hunt and Des. But remember, this is more of a subjective grading. And currently, nobody likes subjective grading, because I can tell mild, you can tell severe. So it all depends subjectively, even though we tell the power. But grading of power in acute scenario is not that good. And we need something that can objectify the severity of a subarachnoid hemorrhage. And this is very inferior, because the most important predictor of mortality in any hemorrhage, I told you, it's the Glasgow Coma Scale. So that is why later on, the neurosurgeons started using something called a WFNS grading. That's called the World Federation of Neurosurgeons grading, which is typically based on the Glasgow Coma Scale and the FND. As I told you, in any hemorrhagic stroke, let it be any hemorrhage, the most important predictor is the admission GCS. That's going to be the most important predictor of your outcome and prognosis. So WFNS gives 5 different grades again, 1, 2, 3, 4, and 5 grades, from mild to moderate to severe. So grade 1 means the GCS is 15 and the patient doesn't have any focal deficit. Grade 2, the patient is having GCS of 13 to 14, mild reduction in the GCS, altered sensorium. At the same time, there is no focal deficit here. And grade 3, the patient is having a GCS of 13 to 14, but with a focal deficit, some form of FND, maybe cranial palsy or hemiparesis, doesn't matter. And grade 4, if the GCS is 7 to 12, and the patient, irrespective of the focal deficit, if the GCS is 7 to 12, it will be under grade 4 only. Anything that is less than 7, that is the GCS is 3 to 6, irrespective of the focal deficit, it is considered as grade 5, which means the GCS is going to be the most important, again in subarachnoid hemorrhage, as a very important prognostic indicator. Lesser the GCS, more poor is going to be the outcome. And apart from this, you have CT grading also. Based on CT also, you can grade the subarachnoid hemorrhage to some extent. This is what we refer to as something called a Fisher classification system or a Fisher grading system. You have 4 types. One is called 1, 2, 3, and 4th grade is there. As far as the first grade is concerned, you don't see any subarachnoid hemorrhage in the CT, which means it could still be positive in the lumbar puncture, but CT is not showing any subarachnoid hemorrhage. And second, you have mild SH or a mild or called as a thin SH, thin subarachnoid hemorrhage, where the sheets of blood will be less than 1 millimeter. Remember, in subarachnoid hemorrhage, you cannot tell the blood volume basically because it is distributed throughout the brain. So if it is distributed in one area, you can tell the volume of the blood that is leaking. For example, in intracerebral hemorrhage, it will be very localized in one particular area. So like an idli, so you can tell. Even in extracerebral hemorrhage, it will be localized in one pocket between the 2 sutures, so it's easier to tell. But whereas in a subdural hemorrhage or a subarachnoid hemorrhage, for example, take a subdural hemorrhage, it is like a dosa, isn't it? Like a dosa, how can you tell the volume of the dosa? Whether the dosa is good or not, you will be actually telling the sheet thickness only. So similarly, in SDH also, the sheet thickness is what is important. Thickness of the bleeding is important. Similarly, in subarachnoid hemorrhage also, the thickness of the bleeding is going to be the most important. So the thin SH less than 1 millimeter thick, then you can think about probably a mild SH, or if it's going to be a thick subarachnoid hemorrhage, which is defined as more than or equal to 1 millimeter thick, and most of the time with focal clots, that will be class 3, and class 4 is intraventricular hemorrhage. Remember, if there is asked, so in grade 5 cutoff should be less than 8. No, not like that. So it's not about coma. See, first of all, what Riju is trying to do is you are trying to equate this Hunt and Des grading with WFNS grading. This is absolutely wrong. First of all, Hunt and Des is completely different and WFNS is completely different. I like your thinking, but that is absolutely wrong. Both are completely different classification systems. This is completely based on the results from different trials. There are 4 trials that have been done on SH. Based on that, only WFNS grading has come. So that's completely different compared to that of the Hunt and Des. You should not equate this coma with this GCS. I mean, I can understand because I've written side by side you are trying to equate, but that's not correct. You should not try to equate that. This is completely different. Don't equate that 5 with that grade 5, WFNS. WFNS is a completely different classification system. And 4 is intraventricular hemorrhage. If they ask you the highest risk of development of obstructive hydrocephalus, highest risk of development of vasospasm, all these things are with grade 3 only, contrary to the belief that grade 4 will cause more problems. No, it's actually grade 3 in CT, especially they have focal clots. And that is very dangerous because they are going to result in highest incidence of obstructive hydrocephalus as well as your vasospasm. Both are going to be having highest risk with this only. I think with this we can finish off the subarachnoid hemorrhage, and I mean these are the maximum number of questions that you're going to get. You're not going to get anything else. And we have some special types of strokes. So I mean with this I'll leave the lunch break. We have some special types of strokes as well. For example, a CVT or a dissecting stroke or a CADASIL. So 3 special types of strokes are there. In this, CVT is very special because it's a venous stroke. It's a venous thrombus that is causing the CVT basically. So what basically happens in the setting of a central venous thrombosis? The risk factor is the same as that of any venous thromboembolism. But CVT has some specialized risk factors. Usual risk factor that we see is severe dehydration. So very commonly we see CVT after an attack of severe dehydration, like patient might be having a fever, not taking sufficient water, sufficient fluids. So they might cause dehydration in this setting, number 1. Apart from that, even severe obesity is a risk factor for development of CVT. Patient who's on oral contraceptive pills is a risk factor for developing, like cerebral venous thrombosis or cortical venous thrombosis. Then we have thrombophilias like factor V Leiden. We know that most common acquired thrombophilia is Apla syndrome, and the most common hereditary thrombophilia is factor V Leiden mutation. So any thrombophilia can produce. Ankita asking why we are preferring nimodipine for subarachnoid hemorrhage, because it's the one that crosses the blood-brain barrier much easily among all the calcium channel blockers. Other calcium channel blockers do not cross the blood-brain barrier that easily. And second thing, it is an extensively studied calcium channel blocker for subarachnoid hemorrhage. That's the reason. So then you have thrombophilia. Thrombophilia can cause this. And neurosurgical procedures can cause. After neurosurgical procedures, you can get CVT. I mean, everyone is telling mastocytitis and otitis media because you are studying about that cortical sinus thrombosis. That's called a lateral sinus thrombosis. That you'll be studying in one of the complications of otitis media. But remember, currently we don't see that much of otitis media causing CVT, cortical venous thrombosis. And more importantly, pregnancy and postpartum. These are common causes rather than what you really think. Otitis media, pregnancy and postpartum. And of course, a chronic complication of a chronic otitis media can produce, but remember, this only produces lateral sinus thrombosis, not the other sinuses. But with the special, but this is very rare nowadays. Chronic otitis media, then a lot of autoimmune disorders because they are basically thrombophilic, can produce cortical venous thrombosis. Then there are few drugs which can cause. As I told you, OCP initially we discussed. Apart from that, any hormone replacement therapy, because they are estrogen containing, they can cause. Tamoxifen can do the same because it's a selective estrogen receptor modulator. Then you can get with steroids. If you use glucocorticoids for long term, then there is something called L-asparaginase, which is used for acute lymphoblastic leukemia commonly. Can produce cortical venous thrombosis. So you have multiple risk factors, all right. But why I'm telling CVT is because there is one important differential diagnosis for that. That is a benign intracranial hypertension. That was previously called as BAH. Currently, the name has been replaced to IAH. That is called idiopathic intracranial hypertension. This is the correct name now. Idiopathic intracranial hypertension. But remember, this is also referred to as pseudotumor cerebrale. All these are old names. All these are old names. And you should not try to confuse with these names, with the current name. That is idiopathic intracranial hypertension. That's the right name right now. And the pseudotumor cerebrale itself has multiple risk factors basically. For example, for pseudotumor cerebrale, one of the important risk factors is once again obesity. Obesity is a very important risk factor, which means there will be multiple correlation with the CVT as well. So that's why I'm discussing side by side as a differential diagnosis. And you can get with OCPs, you can get with a lot of endocrine issues. Endocrine problems like hypothyroidism can produce benign intracranial hypertension. Then acromegaly can cause benign intracranial hypertension. Or for example, you have Cushing's can produce BH. Even for that matter, Addison's can produce BH. Then, of course, you have certain drugs which can produce BH, like OCP we have discussed already, is a risk factor for developing BH. Then vitamin A toxicity, glucocorticoids and steroid withdrawal, both are associated with benign intracranial hypertension. Risk factors for developing benign intracranial hypertension. More than that, it can be completely idiopathic. These are only the risk factors, but usually we don't know what is the real association with benign intracranial hypertension. But what you are seeing here is there is a considerable overlap between the risk factors between these two. Patients can be obese, using OCPs, can be having multiple issues. In that, this vitamin A toxicity is a very commonly asked question in exam, because vitamin A toxicity can happen in the setting of a retinoic acid use, especially females. Those who are using these drugs for acne, severe acne, they can develop benign intracranial hypertension. Even growth hormone therapy, very important cause. I told you acromegaly can cause. So in children who are receiving growth hormones because of poor growth, short stature, they can also develop benign intracranial hypertension, pseudotumor cerebrale. One of the important side effects of growth hormone therapy is benign intracranial hypertension only, which can really happen. But it's important to differentiate these two disorders. I mean, even though it's very easy, but it's very important in certain settings. First, let me describe how these disorders will present. They can come in as an acute event or a subacute to chronic event also. Subacute to chronic is very rare, but acute is the most common presentation. So usually acute presentations will be very dramatic. They'll be having features of raised ICP. Number one, all the features of raised ICP will be there because of the backlog. Veins are not draining properly, so there will be so much of blood within the cranial cavity. More blood means definitely you're going to raise the intracranial pressure. So you're going to definitely have issues with this. So raised ICP in the sense you'll be getting headache, severe vomiting, and all will start very acutely if it's an acute CVT. And they may develop altered mental status. They may develop focal logical deficit. Rare, but they can still develop focal logical deficit, or they may develop seizures as well. So all the features of raised ICP will start. And fundus we are not going to do anyway here. If you do a fundus, it can be normal or they can show papilledema because of the raised ICP, depending on how fast the ICP is rising. On the other hand, your subacute to chronic cases most commonly will present with headache only. Plus or minus, they can have vomiting. So when you tell that the headache is due to raised ICP, we are talking about headache and raised ICP. I mean, this is very important in a chronic raised ICP. Whenever the patient is having a chronic raised ICP, what is the type of headache that will get? What are the clinical features of the headache that will tell you that the patient is having a chronically raised ICP? Or I'm asking about raised ICP related headache will be of what presentation? Any idea? Definitely not pulsatile. It will not be pulsatile. We're not talking about a migraine here. Yes, that's more important. Keshav told that is postural variation. That's very important, especially when they move towards the gravity. Headache will increase. For example, they bend down, when they lie down, or when they bend down to put their shoelaces. So during that time, the headache will be very severe, and lying down will make the headache worse. When they move towards the gravity, their headache will increase. That's one. Second, headache that increases on coughing and straining. So when they cough or when they strain in the bathroom, so during coughing and straining, if the headache increases, that's also a sign of raised ICP. In that setting, you have to be a little careful. Even though it can happen in other benign kinds of headache also, but these are signs that the headache can be very dangerous. That is due to a raised ICP. So headache that is increasing towards gravity when you move towards gravity, or a headache that is increased with coughing or straining. So these are the 2 points. So usually that's how they present headache. Usually subacute chronic cases, they will not have any altered mental status, or rarely they will have a focal logical deficit or a seizure. So whereas benign intracranial hypertension usually will be a chronic condition, idiopathic intracranial hypertension. So they will come with a chronic headache only, without any doubt. And usually whenever you do a fundus examination for a chronic headache, because the patient is coming with chronic headache, they'll be having a papilledema in the fundus. So papilledema definitely is a sign of raised ICP, without a doubt. And the headache that the patient is having is also will be like something like a raised ICP only, like what I've told you some time back. But if you take an MRI, so you want to do an MRI and an imaging in these patients, it will be completely normal. You will not see anything at all. So you'll be feeling like, what's happening here? I'm having a papilledema, raised headache, but the patient is having no problem at all. Absolutely all right. So what I should do here, and if you do a perimetry, because this is a chronic papilledema, this papilledema will be for a long time. If you do a perimetry, you will see clear-cut visual field defects. Can anyone tell what is the most common visual field defect that is associated with papilledema? Most common visual field defect of the papilledema. Yes, correct. Enlargement of the blind spot, which means patient will not be even aware of that the patient is having a visual field defect. Because if the blind spot is the one that is getting enlarged, you will not be really knowing. So now when you're seeing something, are you seeing where is your blind spot? You can see your blind spot, own blind spot. There are multiple techniques are there. But in your own, like fingers, you can see where is the blind spot. You can find out that, but you are not really aware of the blind spot. So these patients also will not be aware of this enlargement of the blind spot unless until there is significant amount of vision that is lost. They will not be even aware that the vision is lost in the first place. So that is a very characteristic feature of a papilledema. That is the one that separates papilledema from optic neuritis. When optic neuritis, the vision loss will be early, at the very early stage, because they lose the central vision. But whereas in papilledema, they don't lose the central vision fast. In fact, it will be very late. Till the time they would have lost substantial amount of peripheral vision. So that's the most common visual field defect. That is enlargement of the blind spot. So perimetry, you might see significant visual field defects. Plus or minus, they might have cranial palsies also. Not only chronic headache, because of the raised ICP, they can have cranial palsies also. And of course, you know, the 6th nerve palsy is going to be the usual cranial nerve that's going to be trapped in this cranial palsies. But usually, one feature that typically separates your CVT from brain arterial hypertension is seizures. Seizures is not a feature of idiopathic intracranial hypertension, but seizure can happen at a very higher rate in the setting of cortical venous thrombosis. So usually, most of the times, even in a chronic CVT, if you do a fundus, very commonly they will show a papilledema. Not chronic, subacute to chronic varieties. Usually they will show a papilledema. So it will be very difficult to differentiate these two clinically. So that is why for this patients with chronic CVT, you will do something called an MRI brain. Along with you will do something called a MR venography. You can do CT venography also, but this is the preferred investigation and a diagnostic investigation. We'll do MR venography also, which is going to clinch you the diagnosis. You will see the filling defects in the cortical veins. So if you see a cortical vein, if you have a thrombus here in one area, and there will be a filling defect. For example, you can see a vein that is getting filled, and if this is the area of a thrombus, beyond this area you will not get a filling. So you can get a filling like this, defective filling. So beyond this there will be a defective filling. Proximally there will be a good filling, which means here there must be a thrombus, which means the dye that you are injecting is not getting filled. This is not an empty delta sign. Come back to that. So in MR venography, you don't see these empty delta signs. What we typically see is the filling defects in MR venography. Then that typically clinches you the diagnosis. Any image, I think I have it. I'll show you in some time. So you typically are going to get something called a filling defect, and that's very characteristic of a like cortical venous thrombosis. Suppose there are some signs are there. For example, if you have CT scan, if you do a plain CT, so plain CT is not a very good investigation for finding out the cortical venous thrombosis, because 30% of the times plain CT can be completely normal. You will not get any problem in the plain CT. So there are certain signs that are described in the plain CT, like you have something called an empty delta sign. Empty delta sign in the CT, I mean plain CT or a CECT, empty delta sign, or you can see something called a cord sign, or you have something called a dense triangle sign. Dense triangle sign. These are the signs that have been described for cortical venous thrombosis, but none of them are either sensitive or specific. This is not really that important anyways. So these are the signs that have been described in the CT scan, but I don't think they're very good. Last is dense triangle sign. The last sign. So empty delta sign, cord sign, dense triangle sign, all these things in CT goes towards the diagnosis of central cortical venous thrombosis only. But of course, when it comes to reality and when it comes to practice and exams, the best investigation is going to be the MRI with MR venography only. That will typically show the filling defects. And CT is sometimes non-diagnostic, and it can be sometimes confusing also, because CT shows some areas of hemorrhage also. CT will show some areas of hemorrhage. And many times it might be thought that this is an hemorrhagic stroke, but even though a good radiologist will not misdiagnose that as a hemorrhage, because the pattern of hemorrhage here will be different. It will be more of a oozing kind of an hemorrhage rather than a leaking kind of an hemorrhage. Oozing is different from rupture and leakage. So it will be more of an oozing kind. The Hounsfield unit will be completely different here. So they'll not really miss, but if it's a beginner, or if a neurologist or a neurosurgeon or a physician is trying to diagnose, they can see some sorts of hemorrhage, because whenever there is a venous obstruction, because of the backlog of the blood, because blood is not able to move forward, there will be venous congestion, and that will ooze the blood into the surrounding areas, and that can result in a venous stroke also. So when you see a newcomer can misdiagnose this as a hemorrhagic stroke, and they can falsely withhold the treatment. Because here the treatment is anticoagulation basically. Only when you give anticoagulation, you can remove the thrombus off, and you can dissolve the thrombus and you will get better. There's no indication for lysis though. You never do thrombolysis, absolutely no indication. But anticoagulation is the mainstay with heparin and warfarin, or probably, as far as I am concerned, in the CVT is concerned, heparin and warfarin is the mainstay. Novel oral anticoagulants are not yet approved for the treatment of cortical venous thrombosis yet. We use still only heparin and warfarin only with proper INR monitoring. Plus or minus, I need to use hyperosmotic agents. hyperosmolar agents. Why I need to use hyperosmolar agents? Because in this scenario, it's important to reduce the ICP. So I need to use hyperosmolar agents like mannitol or 3% NaCl. We'll be discussing about that in detail later on, why we use mannitol and 3% NaCl in this kind of scenario. So I'll be using mannitol and 3% NaCl. Lysis, why it is not? Because there is a very high risk of bleeding. Veins will be very fragile. And for venous thrombosis, generally we don't use lysis. It will not be that effective. Even that's why DVT and PE itself, we don't do that much lysis. Arterial thrombosis may respond to lysis, but venous thrombosis usually will not respond to lysis. Especially in the brain, there is a significant and substantially high risk of bleeding with the lysis, and we never do it. So mainstay is anticoagulation. With or without, you're going to start with hyperosmolar agents to reduce the ICP. That's all. So this is how you are going to treat a CVT. Easy. That's not a big deal. But as far as your benign intracranial hypertension is concerned, since your MRI is normal, but your fundus is showing papilledema, I mean, you need to confirm that the disease is having some issue. I mean, some signs of raised ICP. So I'll be going for a CSF manometry. This is the investigation I'll be preferring. So CSF manometry is the investigation that I should prefer. Once I do a CSF manometry, what I'll be looking for is the opening pressure. Opening pressure. So usually any opening pressure of more than 25 centimeters of 25 centimeters of water in a patient who's having these features, having a headache, papilledema, plus or minus a visual field defect in perimetry, and having a normal MRI, not showing any signs. So in that setting, this is diagnostic. So opening pressure of more than 25 centimeters of water is basically diagnostic of a, what is that? Benign intracranial hypertension or idiopathic intracranial hypertension. Remember, the normal opening pressure is somewhere around 5 to 20 centimeters of water. Or you can write as 50 to 180 millimeters of water also. But approximately it is around 5 to 20 centimeters of water. This is the normal opening pressure. If it's more than 25 centimeters of water, you can make a diagnosis. If the MRI is normal, the MRI is showing mass lesion, then that's completely different. One common finding, I mean, even though I told you it's a normal MRI, that's what you will get in exams. But one common finding that you can encounter in MRI is the empty cella syndrome. That's because high pressures may compress the pituitary to go down, deep down into the CSF. So you may not be looking at you can not be able to look at the pituitary properly in the CSF. You may not be able to look at the pituitary properly in the cella turcica. That is what we refer to as empty cella. And that's a very common finding in a idiopathic intracranial hypertension. So if the radiologist doesn't see anything in MRI, completely normal MRI, if he sees only empty cella, then they will give, consider the possibility of benign intracranial hypertension. That's what they're going to give. And if you see this constellation of findings, whatever I told you, it should be very precise for you. Then you are going to go for CSF manometry. And if you prove that the opening pressure is elevated, despite having a normal MRI, no mass lesion, but having clinical signs of raised ICP, then of course you're going to diagnose a idiopathic intracranial hypertension in this setting. And what's going to be the treatment? Treatment of IAH, initially the first line treatment is, I'm going to use astazolamide. Astazolamide, we know it's a carbonic anhydrase inhibitor. CSF is full of water, we know. Carbonic anhydrase is very important to produce water in the CSF. When you give a carbonic anhydrase inhibitor like astazolamide, the water production in the CSF will be reduced. So once water production is reduced, since CSF is 99% water, of course, you are going to result in reduced amount of CSF production. So that might reduce the intracranial pressure, and that might be helpful in your relieving of the headache. Or you can use an alternative drug called topiramate. So what is the advantage of using topiramate here? Topiramate is one of the only antiepileptics. Two antiepileptics are there. One is called topiramate and second is called zonisamide. You would have heard. But topiramate is very commonly used compared to the zonisamide. Zonisamide is not very commonly available in India. So when you take these two antiepileptic drugs, topiramate and zonisamide, both can cause substantial amount of weight loss. You know that. They are weight-losing antiepileptic drugs. Exactly opposite to valproate, which is a severely weight-gaining antiepileptic drug. But topiramate and zonisamide are weight-losing antiepileptic drugs. And at the same time, they are two drugs which carbonic anhydrase inhibiting activity also. That's why we are using here. Like astazolamide, topiramate and zonisamide are having carbonic anhydrase inhibiting potential also. Along with that, they can reduce the weight. So this is having multiple advantages. They can reduce the CSF production like astazolamide. So they can produce reduction in the ICP. At the same time, many of these patients with idiopathic intracranial hypertension will be extremely obese. So giving topiramate and zonisamide, I mean, in this setting we use topiramate. Giving topiramate may be advantageous in reducing the weight as well. But topiramate has a lot of side effects like sedation. I mean, Shubham is telling renal stones. Of course, yes. This is effective in reducing weight and it has carbonic anhydrase inhibiting activity. So it is beneficial in IH patients. But of course, it has some side effects like renal stones, heavy sedation are there. But we'll be discussing subsequently in the Caesar topic, not here. So these are the first line therapy. Then if they don't respond, to this first line drugs, I mean, there are some books which gives glucocorticoids that can be used, but currently we don't use steroids as a important therapy in IAH. They tend to use steroids previously, prednisolone and all, especially if they have visual field defects, but there is no, like rationale right now. Many studies have told against usage of steroids in benign intracranial hypertension. So in this setting, you see what is the major issue for the patient. You have to go for some intervention. See what is the major problem for the patient or major issue with the patient. Either it's the headache that is concerning the patient, that's not coming down or intractable, or it's the visual field defect that is worsening. What is the primary issue? So if the headache that is the primary concern for the patient, then the best surgery will be something called a LP shunt. That's called a lumboperitoneal shunt. It's a very easy procedure. From the lumbar cavity, lumbar spinal cord, you're going to produce a shunting of the CSF towards the peritoneal cavity. That's called a lumboperitoneal shunt. If you think visual field defect is the major issue here, then you can go for something called optic nerve fenestrations. Both are excellent procedures, by the way, but you can do any one of the procedure. I mean, depending on what is your primary problem. Both can be helpful in both. I'm not telling optic nerve fenestration will be helpful only for visual field defects. It can reduce a headache also, but see which is the primary issue for the patient. So depending on what is the primary issue, you can either do a optic nerve fenestration or you can do a lumboperitoneal shunt. So this is how you are going to treat a benign intracranial hypertension. So both are basically headache related disorders. So many times, even though I put it under stroke, I've discussed under stroke, but BH usually does not cause any stroke, even though they can rarely cause a 6 nerve palsy and focal neurological deficit, but BH usually does not cause stroke. And CVT and BH both will be discussed in the headache disorders also. Last part. What is the last part you want to know? You want to see this? Okay. So I think it's 2 o'clock now, so you can go for the break as of now. We can come back and we can discuss the remaining portions of stroke, because we have only touched the surface of the stroke. We have the stroke localization, stroke treatment, and we have so many other stuff. So 3 o'clock, you come at 3 o'clock. Let us see what's happening there. Okay, bye-bye. See you.